Welcome to the second meeting of Joint Interim Standing Committee on Health and Human Services. We can call the roll first. Members, would you please turn on your cameras and respond when you hear your name? Mr. Ashton, would you please call the roll?
Thank you, Chair Peters. Senator Toniate? Senator Hardy? Senator Harris?
Present.
Assemblywoman Golo?
Here.
Assemblyman Haven?
Here.
Assemblyman Orndlicker?
Here.
Assemblywoman Titus?
Here.
Chair Peters.
Here. Please mark members who are not here as present upon their arrival. So we have a full agenda today again, and we're ready to talk about substance abuse and the opioid crisis, the landscape for treatment and recovery. We will wrap the day up with an overview of the bills that were passed during the 2021 legislative session pertaining to this issue area. This particular area can be very personal for folks, and I appreciate the emotions that can come up from the discussion of substance abuse and recovery. This is a heavy issue, and I want to respect what comes up for us in this area. So please let me know if you need to step away at any point, take a break, take a breather, turn off your camera if you need to. Depending on the length of the question and answer for the first few agenda items, we will plan to take a quick lunch around 1 p.m. Unfortunately, due to some unforeseen changes in our agenda, we will be skipping agenda item 10 today. Dr. Kelly is unavailable due to a family emergency. Then send our thoughts, and we'll try to reschedule that important topic. Additionally, we will hear agenda item 14 right after agenda item 5. Since we have the presenter here for both of those items. A couple of housekeeping items before, let's see, first I want to remind you to please silence all of your electronic devices. Mine just went off, so I will do that myself. Please keep yourself muted and when you are not speaking, but leave your camera on so we can maintain a quorum of those who are on the meeting. Additionally, I ask our presenters on the Zoom meeting to leave your cameras off and microphones muted until I call up the agenda item under which you will present, or if I direct any questions to you. The Zoom meeting has a chat feature. However, this feature is only to be used for technical assistance. Any links or information that you would like to share during your presentation should be stated verbally on the record, and we can do follow-up with staff if there's additional items you'd like to share. Agenda items may be taken in different order than listed. 2 or more agenda items may be combined for consideration. An item may be removed from the agenda, and the discussion of an item on this agenda may be delayed at any time. The committee's meeting material can be found on the Nevada Legislature's website. You can also sign up for electronic notification related to any activity on the committee's website. We will have a public comment period at the beginning and end of the meeting. Public comment is limited to 2 minutes per speaker to allow for fair timing for everybody. This virtual meeting format is important to keep everyone safe during the COVID-19 pandemic. Members of the public may provide comment in 4 different ways, all of which are listed on the agenda. You can provide public comment by calling 669-900-6833, entering meeting ID 842-8692-2636, and then pressing the pound sign. When prompted for a participant ID, please just press the pound sign again. You may also email comments to the committee email address, that is hhsinterim@lcb.state.nv.us. You may also mail written comment addressed to the Research Division, 401 South Carson Street, Carson City, Nevada, 89701. And for your convenience, we still have a fax number. That number is 775-684-6400. You can find all of this information on the agenda. And with that, we'll move to public comment. Public comment will be limited to 2 minutes per speaker. Staff will time each speaker during public comment to ensure everyone has a fair opportunity to speak. We also ask that you do not repeat what a previous commenter stated. An additional opportunity to make public comment will be available at the end of the meeting. Our broadcast and production services, or BPS staff, will interact with those making public comment to facilitate participation. BPS, please add the first caller with public comment to the meeting.
Thank you so much, Chair Peters. If you'd like to provide public comment at this time, please press *9 on your phone to take your place in the queue. Caller with the last 3 digits, 918. You are unmuted and may proceed.
Thank you. My name is Leanne Mcallister. I am the Executive Director of the Nevada Chapter of the American Academy of Pediatrics. Thank you for prioritizing discussing substance abuse at today's meeting. Pediatricians have long been ringing the alarm on the impact of the opioid epidemic on children's health, witnessing its devastating consequences in their clinics and communities. The Nevada AAP strongly advocates that treatment is prioritized over criminal prosecution. Incarceration and the threat of incarceration do not reduce the incidence of alcohol or drug use and can deter pregnant women who need help from seeking prenatal care. This is also harmful to children. Studies have shown that receiving prenatal care significantly reduces the negative effects of substance abuse during pregnancy, including low birth weight and premature birth. The Nevada AAP currently has 276 members, most of whom are board-certified pediatricians, both primary and specialty care. Members also include pediatric nurse practitioners, physician assistants, pediatric residents, and medical students, all of whom live and work in Nevada and have dedicated their professional lives to the health of all children. Thank you.
Thank you. Please go ahead and add the next caller.
Caller with the last 3 digits, 324. You're unmuted and may proceed.
Good morning, Chair Peters and members of the committee. My name is Stephen Messenger, STEVEN-MESSINGER, and I'm the Policy Director for the Nevada Primary Care Association. We're the state membership association for community health centers, also known as federally qualified health centers, or FQHCs. We've been grateful to be the recipient of nearly 1.2 million state-administered grant dollars used to boost capacity to treat substance use disorder in our member clinics located across the state. Our FQHCs are a critical tool for bringing these services to underserved populations and rural communities, and this grant has allowed us to expand their ability to deliver these crucial services. However, there are steps the legislature could take to make this effort much more effective. This legislative body could request a bill approving an expansion of available behavioral health provider types to practice in FQHCs and be reimbursed by Medicaid. This list includes licensed alcohol and drug counselors, marriage and family therapists, and certified professional counselors. As this committee turns its attention to the efforts to mitigate the opioid crisis and substance use disorders broadly, we urge you to consider expanding the types of addiction specialists and other behavioral provider types to provide sustainable services to our most underserved populations. Thank you for your time.
Thank you for your comments. Are there any other callers on the public line for public comment?
Chair, your public line is open and working. However, there are no more callers at this time.
Thank you so much. That we will go ahead and move on to our next agenda item. This agenda item, consideration for regulations proposed or adopted by certain licensing board, will be presented by our legal counsel, Eric Robbins. Eric Robbins will make some opening remarks, and then members may ask questions on these regulations. We are not, sorry, excuse me. This is an informational item only. Staff informed you about the status of the regulatory process of the 2 regulations that we are considering now. We received an email, I believe, from our legal staff. you have a greater interest in participating in the development of these regulations, the process can be found on the LCB website, or you can reach out to our staff for additional assistance. Committee review is an important process for follow-up on bills that have passed in the last couple of sessions, but we will be not be taking any action on these items today. For the regulatory process, I just want to note that this committee neither approves nor denies any of the regulations before you today. Instead, each board adopts its own regulations followed by approval through the Legislative Commission. The HHS committee's consideration of these regulations is only from an advisory perspective. If you need further detail on the regulatory process, please direct those questions to our LCB staff after the meeting. We'll go ahead and ask Mr. Robbins to please present these two regulations.
Hello, this is Eric Robbins from the Legal Division of the Legislative Counsel Bureau. We have two regulations for the review of the committee today. Both are proposed by the Board of Medical Examiners. We have Regulation R171-20, which revises various provisions concerning the licensure and regulation with regard to the practice of medicine. And then we have R180-20, which revises qualifications for certain applicants for licensure as a physician assistant. And we should have Sarah Bradley from the Board of Medical Examiners here to answer any questions from members of the committee.
Thank you so much. Are there any questions on these regulations from the committee?
Madam Chair.
Go ahead, Assemblywoman Titus.
Thank you. Just a quick question regarding these regulations, Mr. Robbins. Where are they in the process? Are they close to being proposed to for passage at the LegCom?
Yes. So one of the R171-20 has not had a workshop or public hearing yet, and my understanding is that the board plans to have those this spring. As for R180-20, the board has had a workshop and public hearing, but has not yet formally adopted the regulation, and they plan to do that later this spring. So neither of these regulations are at the stage yet where they would be presented to the Legislative Commission.
Thank you. And Madam Chair, may I ask a question of the representative from the BME?
Yes, please go ahead. See if they will pop up here. Who do we have? Oh, yeah. There it is. Ms. Bradley.
Having heard. Great, thank you. Great. Good morning. So I've been a member of the BME, and I do appreciate all the work that goes into making sure the citizens of the state of Nevada are protected, and that we have good medical doctors, we have good PAs, and all of those things. I'm concerned about this particular regulation, R171-20, section number 8, and then going down to number 2 of section 8, where you're removing the requirement that the person is going to practice medicine in the state of Nevada if they're not a citizen or are here in good status. And so how will you, does it not matter to the state anymore that they're a legal immigrant or that they're here legally, or can you clarify that for me? Is it are you going to look somewhere else, or can you explain why you're removing that?
So, Madam Chair, members of the committee, Sarah Bradley, Deputy Executive Director. The reason for the change in Section 8 that you're pointing out is to be consistent with changes in the NRS that were enacted, I want to say in the 2019 legislative session, because for physicians, so this is for, basically, we're just trying to make it clear because the requirement of citizenship or lawful status was removed from all of the other license types that are in our NRS. And so we're just doing this to be consistent with those changes in the NRS.
Thank you, Ms. Bradley. I also think that Mr. Robbins can speak to that a little bit as well.
Yes, Eric Robbins, LCB Legal. In just to clarify the changes that Ms. Bradley was talking about. NRS 622.238, which was added during the 2019 legislative session, provides that notwithstanding any other provision of Title 54, a regulatory body shall not deny the application of a person for the issuance of a license pursuant to this title based solely on his or her immigration or citizenship status.
Thank you for that. So for clarity, I mean, I recognize it's taken us sometimes 8 years to bring a nurse in from, say the Philippines, where we have gotten a lot of nurses for our hospital, but it took 8 years to get to happen and a lot of process. So, but we still had to have them come in on a legal status. So now that's one of the things that's going to be eliminated for docs and all, is just to expedite the licensure process, because I just want to make sure we have good oversight.
Again, Madam Chair and members of the committee, I mean, the intent here is to make this regulation consistent with the rest of the NRS provisions that the legislature has passed and enacted. So the board isn't, I mean, it's not my intent to make any position on this. We're just going to go ahead and make sure that people have the appropriate education and things like that. And whether they're able to lawfully work or not is really not a question for the board, in my view, especially given the direction the legislature gave us in 2019.
Thank you,
All right,
Ms.
thank
Brown.
you. And thank you,
Yeah.
thank you, Madam Chair, for the questions.
You're welcome. Thank you so much. And I do appreciate that the board is taking those steps to be consistent with what we have decided in the legislature is important to licensing in Nevada. Senator Hardy, I see your hand up as well. Do you have a question on one of these regulations?
Yeah, thank you, Madam Chair. Along that same regulation, so I'm aware, for instance, of a person who was an MD in the Philippines and came to the United States and now working as a medical assistant. So are we proposing to allow other nations' physicians who come here legally to be licensed as physicians without having to jump through any other hoops as physicians?
I'm going to go ahead and jump in, Ms. Bradley, that I believe this only pertains to consideration of citizenship, not to education or those other background pieces that are important to ensuring that our licensed physicians are well educated in the areas of importance in Nevada and the United States.
That sounds wonderful, Madam Chair. I guess I didn't phrase my question. Are physicians someplace elsewhere going to be allowed to be physicians in the state of Nevada without having to go to school and repeat their medical education that they got somewhere else?
I'm happy to jump in here, Senator Hardy.
You froze.
Oh, I think we temporarily lost Mr. Robert.
Licensing doctors does not affect any of the other educational qualifications. So they would still have to have the educational qualifications prescribed by statute. And it just, as the chair said, it just says that what the statute already says, that the board can't deny a license based on citizenship status, but they still could deny a license based on educational qualifications. And in fact, they would have to deny the license if they don't have the educational qualifications prescribed in statute.
So that brings me to the question, Madam Chair. So if a person from Canada comes to the United States, bona fide physician, it's my understanding that we accept Canada medical schools as qualified education. Do we accept any other countries, or do we preclude any other countries from accepting their medical doctorate degree? Or do we have in statute that we only accept the medical doctor degrees from the United States or the residencies from the United States? Where are we with that? Does this appreciably change anything that we do now that will preclude somebody from someplace elsewhere getting the right to be approved by the Board of Medical Examiners because they have an MD somewhere or a DO somewhere? Will they not be allowed to practice here?
So, Madam Chair, members of the committee, Sarah Bradley, Deputy Executive Director, again for the record. We're already licensing foreign trained doctors every day. And this just, again, speaks to the status to work, this regulation anyway. And what the thought is that you can get a license and perhaps then be able to find a job and be able to get your lawful status. But I mean, we have doctors right now that have obtained degrees from universities in India, universities in Mexico, all over the country. There's a process in the statutes, and I could get the exact statute for the chair and the members of the committee if you'd like, that talks about the foreign approval process, because there are certain universities that offer MD degrees that are already like vetted and approved. It's a foreign like equivalency review that's done. Again, this regulation doesn't affect that. It's already in place in the Nevada revised statutes that, and again, I know because I look at applications and I see files every day. We have many doctors trained in other countries that are practicing in Nevada at the moment.
So let me follow that up if you might. So is there a list of countries that we accept and a list of countries that we don't accept their medical degree from?
I'm not aware of a list of countries. I'm aware of a list of schools. And again, the review is done by an outside entity. It's specified in the NRS. I can try to pull it up now, but I'm just concerned I won't find it timely and I may find the wrong provision. But it's like, it's an acronym that we use and it stands for, it's a foreign equivalency review. And again, there's many universities that are already pre-approved. And then there's others that they can submit to that review. And if that entity deems them equivalent to the approved programs, then they would be eligible for licensure in Nevada. And I've worked in licensing for 15 years, my career. I've only been at the board for 2 years, but this is very common for all professions. I've seen this with every profession, every licensing board I've ever worked with, that there's an option for foreign education review. And there are people licensed as long as it's deemed equivalent.
And so there is a list of these schools that have been pre-approved. And if you go to that school, get your medical doctorate of some kind, you can come here and be approved. Are there any other hoops that they have to jump through than we already do?
Well, I mean, they already have an approved residency. They have to meet all the requirements that we require of all applicants. So education is just one piece. There's also the residency, as well as an exam requirement and other things. And so the entity, it's a foreign entity. It's not a third party entity. It's not a Nevada entity that rates these schools. And I'm sure on their website, they would have a list. I don't have a list right now. I can provide the chair and the members of the committee with the statute that talks about this process if you would like, Madam Chair.
Thank you, Ms. Bradley. I would appreciate that. As this isn't directly related to the piece of regulation that we're looking at under this item, I'm going to ask that any additional questions, Senator Hardy, be directed to Ms. Bradley or to staff off the line, and that follow-up can occur there. This seems like a really important issue that you're impassioned about. And I know from personal experience, having tried to go to school from an engineering school in Nevada to an engineering school in Australia, that they're not always considered equivalent. So it's important to know where you stand with those education requirements.
I think, Madam Chair, if I may, not to belabor, but if we are doing this with other countries, we need to open the doors to Nevada and recruit from other places, as well as recognize that they have opportunities to come here. So I would love to have the list of medical schools. I would love to have the public know this. And I think that's one of the challenges I have with this particular regulation is I think we put the cart before the horse. The public hasn't seen this yet. And so we are reviewing something that the public hasn't had an opportunity to see it. So we're going to, in essence, approve something that the public hasn't seen yet, which is not the tradition that we've had in the legislature. And so I have.
Well, I want to just step in about what our role here is. Our role here is to provide input into the process. It is not to make decisions. We are not approving these. We are not suggesting the approval by the LegCom either. We are just reviewing these as they pertain to the legislation that has passed in previous sessions. There is a public input process, and as an elected official, you are more than welcome to reach out to these boards and entities who are proposing these regulations to provide your input at that process. And you're right, the public does get an additional input process where they will have access to these regulations from our website today and are able to then follow up through that public input process as those meetings are set up through the spring and summer. So I additionally agree that we should be looking at how to encourage folks to come to Nevada, because our healthcare industry really could use that boost in the numbers of providers. And I would also encourage you to take that up with maybe GoEd or one of the economic development groups that reaches out to other countries and works with them on bringing people into Nevada and encouraging those industries. So I'm going to go ahead and move on from this topic if there are no additional questions, maybe on the other side of regulations.
Thank you, Madam Chair.
Thank you, Senator. All right. With that, we're going to, thank you so much, Mr. Robbins. We're going to go ahead and move on to agenda item number 4. We have the honor today of hearing from Honorable Aaron Ford, our Attorney General. He will be doing a brief introduction today on some of the work that their office has been doing on the opioid epidemic.
Good morning, Chair Peters and members of the committee. Aaron Ford, your Attorney General. And I'd like to begin by thanking you all for the opportunity to provide some opening remarks for today's Interim Standing Committee on Health and Human Services. And as an aside, I'd like to say hello to all of my good friends. Some of you are my former colleagues in the legislature. Great to see you. Hello, Senator Hardy, Dr. Titus, and I love the beard. I love the beard, Senator Hafen. I'm trying to get that one day. In any event, thank you again for having me. In Nevada, we have seen significant legislation passed and a remarkable coordinated effort undertaken to address the opioid and drug epidemic in our state. Before the pandemic, these efforts had begun to bear fruit. We had seen decreases in the number of opioids prescribed, and more importantly, both non-fatal and fatal overdoses. Unfortunately, with the start, we began to see unprecedented increases in non-fatal and fatal overdoses, most of which were related to the illicit use of opioids. According to the Department of Health and Human Services Office of Analytics, Nevada saw a larger number of opioid overdose deaths in 2020 at 484 than the previous peak in 2011 of 460. Nevada was not the only state to see high overdose numbers. In fact, according to the CDC, there were over 100,000 overdose deaths in the United States between April 2020 and April 2021. Many of these deaths, as I've alluded to, can be traced back to illicit use, such as fentanyl, a disturbingly common drug with a potency more than 100 times that of heroin. Often people do not realize that the drugs that they have procured are laced with fentanyl, and deadly results occur when they take too much unknowingly. Every death caused by the drug epidemic is a tragedy, and every overdose must be seen as a reason to continue our work. One death, one overdose is one too many. One area in which Nevada has made improvements is in our substance use surveillance activities. These activities, as we will discuss further, allow us to understand what is going on in our communities, how to better address these issues, and hopefully how to prevent overdoses and death from substance misuse. Today, you will hear about the surveillance systems currently in place in Nevada that inform us of fatal and non-fatal overdoses. Steps to better aid us in our fight against the opioid epidemic were also taken in the 2021 legislative session with the passage of both Assembly Bill 374 and Senate Bill 390. I'm going to speak a little bit about the focus of what these bills created and their importance in fighting the opioid epidemic. AB 374 created the statewide Substance Use Response Working Group, also referred to as the SURGE. I chair that group. Senate Bill 390 created the Advisory Committee for a Resilient Nevada, also called the ACRN, and the Fund for a Resilient Nevada. The SURGE and the ACRN provide recommendations for the use of money from the Fund for a Resilient Nevada. The majority of money that goes into the Fund for a Resilient Nevada originates from opioid litigation settlement funds recovered by my office. As you know, my office secured a $45 million settlement from McKinsey in 2021. Monies from that settlement were transferred to the Fund for a Resilient Nevada. And earlier this year, I announced that my office has also secured over $280 million in additional settlements with manufacturer and distributor defendants. Millions will be transferred to the fund from those recoveries this year as well. I can't praise those enough who have worked on opioid litigation and negotiated these settlements to assist in battling the substance use crisis currently afflicting Nevadans. I also can't praise enough the efforts of the employees of the DHHS, who have also worked so hard and continue to work so hard in their efforts to fight this epidemic. The task of creating a needs assessment and state plan to use this money in a coordinated and strategic effort to fight this crisis is how Nevada is going to win this fight and save lives. The staff of DHHS has also worked so hard to support my office's litigation in providing terabytes of data through discovery, and I wanted to be sure to recognize and thank them for their great work. Again, thank you all for these opening remarks, and I'd like to extend my personal gratitude for your efforts to help all Nevadans affected by this drug crisis. And with that, Chair Peters, I tender the mic back, and thank you so much for the opportunity to be here this morning.
Thank you so much, Attorney General Ford. We really appreciate you taking time out of your day to come and speak with us a little bit about this important issue. We look forward to hearing more about how things are going in those programs and where Nevada stands today and how we can help.
Thank you so much. If I may be excused.
Please.
Thanks. Bye, everybody.
Well, thank you so much. We're going to go ahead with those remarks, move on to agenda item 5, our substance use overdose surveillance data presentation. And we're going to be looking at trends, gaps, and policy considerations to improve data surveillance. We have quite a few folks here to present this, but I believe that Kyra Morgan, our state biostatistician, will be kicking us off. If I'm incorrect, please go ahead and correct me. It looks like we've got your presentation up on the screen, so please proceed when you're ready.
Thank you, and good morning, everyone. I'm Kyra Morgan. I'm the state biostatistician for the Department of Health and Human Services. And I'm just going to kick off this presentation with a data update to really highlight substance use in Nevada and talk about a little bit of where we've been and where we are currently. So first, I wanted to just set the stage with some national and regional comparisons. According to the Substance Abuse and Mental Health Services Administration, the prevalence of last year's substance use disorder in Nevada was 9.5%, and the prevalence of last year's alcohol use disorder in Nevada was 6.2%. I did want to touch on at a high level the data sources that we're using. We do have 3 resources available at the top of this screen, and most of the data in my presentation were pulled directly from those resources. They are publicly available and updated regularly. The first is the Behavioral Health, Wellness, and Prevention EPI profile, which comes out every 2 years. We also have an opioid surveillance dashboard and a methamphetamine and stimulant surveillance dashboard that are updated regularly. And then there's some data sources listed here I'm not going to get into in the interest of time, but I did want to go through these definitions because they're going to be important as I go through some of the data on the following slides. I'm going to talk about alcohol and drug-related emergency department encounters. Those are visits where alcohol and drug use or abuse is listed as part of the diagnosis, but it's not necessarily an acute life-threatening overdose type of a situation. Same thing with alcohol and drug-related inpatient admissions. Those are inpatient stays where alcohol or drug use or abuse is listed as part of the diagnosis, but not necessarily in a life-threatening way. And then we're going to get into a little bit of information on poisonings, and those are where the primary reason for the visit is an overdose, and the patient record has specific billing codes for overdose or poisoning. And then I'll touch highly on drug and alcohol-related deaths, and these are defined as a death where a contributing factor to cause of death included drugs or alcohol. So first, this is information from our behavioral risk factor surveillance survey. It asks during the past 30 days on how many days did you use marijuana or hashish or other illegal drugs, prescription drugs without a doctor's order, just to feel good or get high. Obviously, you can see significant increases in marijuana use spanning the entire time period, with a significant jump in 2017 when marijuana became legal recreationally. And in 2020, about 1 in 5 Nevadans surveyed indicated that they had used marijuana in the past 30 days. We also do see a significant increase, although the magnitude is much lower, related to illegal drugs. That's the orange line. And you see, respectively, a pretty significant increase between 2019 and 2020, even though the magnitude is significantly lower. This slide looks at emergency department encounters. So I'll try to just give a brief interpretation of each of these graphs because I realize that there's a lot to interpret in one presentation. But this looks at alcohol and drug trends in an emergency department setting, again, non-overdose encounters. And so you'll notice between 2012 and 2014, we saw alcohol presenting more commonly than drug use and abuse. And since 2014, really that has switched, and we've seen more drug use and abuse in our emergency department than alcohol. Just to put kind of a general magnitude of disease burden on this, in any given quarter of 2021, we saw approximately 8,600 alcohol and 9,300 drug-related visits to Nevada emergency rooms. Also, just worth noting the stark increases in drug-related visits between 2012 and 2016, and then really a little bit of decline, and in general, just stability since then, whereas alcohol visits have started to increase again over the past several years. This is drilling down into that drug category. So it's the same exact metric, but we're looking at the specific type of drugs that were present in those individuals. One thing I want to make sure everyone's clear of is that these groups are not mutually exclusive. In other words, I might present to the emergency department with multiple, being indicated that I use or abuse multiple types of drugs. And so an individual could be counted multiple times across this graphic. But I want to draw your attention to the trend related to methamphetamines, which is that dark orange line that you see increasing most significantly. The gray dotted line is marijuana, so we saw a significant increase, and then it's since been declining since about 2017. And then opioids there in the blue line increased until about 2017, and then have decreased since then. This is the inpatient setting, but same data. So these are people who were admitted overnight, at least, to the hospital. And really the same story. Alcohol and drug use were kind of on par until 2014, when drug use really started to grow much more significantly than alcohol use. I do also want to just express to use caution interpreting 2020 and 2021. The reason for that is that we know the COVID-19 pandemic has changed utilization patterns in our hospital setting. A lot of practices have been put in place to, reserve room for patients that really need it. And we've seen across the board utilization is down in 2020 and 2021. And so I'm not quite comfortable making the assumption that the declines that we see here are related to a reduced burden in the community. It's probably more likely that that's based on utilization patterns and is probably an artifact of the COVID-19 pandemic. When we're looking at inpatient admissions, there were approximately 5,300 alcohol and 8,400 drug-related admissions to Nevada hospitals in any given quarter of 2021. And again, this just drills down into that drug category to try to explain which drugs are being seen most frequently as being used by these individuals in the hospital. Marijuana is most frequent and has grown pretty significantly over time. But that second line is probably most concerning. That's methamphetamines, with just really significant growth over the span of the graph here. And then you'll see the blue line, opioids, really was growing and then has kind of leveled off and started to decline. Cocaine's been relatively stable. That's the green line near the bottom of the graphic. I did throw in just one slide here on poisonings. I know the people, my colleagues that are presenting later are going to go into more detail related to regional poisonings in both Clark County and Washoe County. And I also realize these graphs are really messy and hard to look at, but I think they're important to include because it is a stark contrast to what we saw when we were looking at the situation, it was not an actual overdose, but was just a presentation of drug use and abuse. When we look specifically at these acute life-threatening drug-related poisonings, opioids are still accounting for the vast majority of those. That's the blue line. On the left-hand side, you're looking at emergency department, and you can see significant increase in 2020 and 2021 related to opioids excluding heroin, and even more significant growth in the orange line, which is your heroin-related emergency department overdoses. Also significant growth in marijuana, and then methamphetamine has really been a little bit more consistent as it relates to these poisonings. The right-hand graph, again, it's really messy, and I apologize for that, but what I want to draw your attention to is that if we kind of ignore, for lack of a better word, 2020 and 2021, knowing that those years are kind of anomalous, and we look specifically at the trend from 2016 to 2019, just really extreme growth in methamphetamine related inpatient admissions for poisonings, and then significant improvement related to opioids and heroin. And so I think that that's indicative of a lot of the policy changes that you're going to hear throughout the presentations today. This is a slide really looking at alcohol and drug-related deaths specifically. The top half of this slide focuses on alcohol-related deaths, and you'll see a significant increase from 2019 to 2020. And then also just want you to know that 2021 data are still preliminary, so we probably will see those numbers actually come in a little bit higher when we have all of those reports in our system. The drug-related deaths graph, the second graph on your screen, shows consistent increase in drug-related deaths, really from about 2015 to 2021. And I did just want to highlight about 1,400 drug-related deaths in 2020, just over 1,500 drug-related deaths in 2021, and pretty consistent year-over-year growth, averaging 14% over the last 2 years. And this is my last slide. This looks at unintentional or undetermined overdose deaths by the specific substances that were present. I want to draw your attention to methamphetamines, which were involved in the highest number of unintentional overdose deaths in both 2019 and 2020, and also observed a significant increase year over year of 44%. Also want to draw your attention to benzodiazepines, which is here kind of in the middle of your screen. They observed overdose deaths related to benzodiazepines increased by 91% year over year. Fentanyl, which is a little bit lower on your screen, fentanyl and fentanyl metabolites increased by 223% from 2019 to 2020. And then lastly, prescription opioids excluding methadone increased by 67% from 2019 to 2020. And that concludes my high-level presentation. And I would defer to the committee and chair if you'd like to take questions or ask questions now, or if you'd like to power through the rest of the presenters.
I think for the sake of time that we should let the presenters get their presentations, get through their presentations, and then we can take questions. I have quite a few questions for you, Ms. Morgan, but I think that for the sake of fairness and those who prepared presentations today, that we get through those. So go ahead. I on my list, I have Elise Monroy next, but that may not be who's on your list as being next. So please, whoever is ready, go ahead and present when you're ready.
Hi, Chair Peters. This is Elise. Brandon DeLisi from Southern Nevada Health District is next.
Perfect. Thank you so much. Mr. DeLisi.
Thank you. Yeah. Thank you and good morning. So my name is Brandon DeLisi. I'm an epidemiologist at the Southern Nevada Health District. I've been an epidemiologist here since 2018, and I lead efforts to monitor, develop, and improve surveillance within the fields of drug overdose and EMS. So thank you all for attending this presentation. So monitoring drug overdose indicators. Should I be sharing the PowerPoint right now?
Yes, please go ahead and share your PowerPoint.
Sure.
Oh, I apologize. I thought I was, is my screen share no longer live?
I don't see it right now.
Screen share is not live.
Perfect.
We are seeing both your primary slide and your next slide.
Is it possible to see just the first slide?
Yes.
Maybe BPS. Oh, there we go. Perfect.
Perfect. So monitoring drug overdose indicators is really important to inform community prevention and response activities. So in the next 5 minutes, I will provide a high-level overview of overdose death data and non-fatal overdose data in Clark County. So using the Health District's electronic death registry system, we can take a look at the overdose death rate for all intents among Clark County residents by drug class from 2015 to 2021. So the figure to the right, or forgive me, can you go back one slide? Kyra? Perfect. So the figure to the right lists the different types of opioids and also benzodiazepines. So if we take a look at all opioid deaths, so they are represented in green. So what we see here is a general decrease from 2015 to 2019. And then from 2019 to 2020, we see a sharp increase in opioid deaths. So I also want to bring to your attention as to what is happening with the light purple line, which represents synthetic opioid deaths. And that category does include fentanyl. So since 2015, we have witnessed an increase all the way through 2021, the largest increase occurring from 2019 to 2020. And the preliminary rate of fatal overdose involving synthetic opioids, again, which does include fentanyl, in 2021 was higher than ever before. Also, fatal overdoses involving fentanyl impacts younger individuals. The median age at death in 2021 was 32 years for a fentanyl overdose and 49 years for a non-fentanyl overdose. Additionally, the rate of fatal overdose involving all opioids and heroin reached its highest in 2020. Next slide. Just like the previous slide, we can take a look at overdose death rate for all intents among Clark County residents by drug class from 2015 to 2021. But instead of all opioids and benzodiazepines, this figure lists psychostimulants, which includes methamphetamine, represented in gray, and cocaine, represented in yellow. So the rate of fatal overdose involving psychostimulants reached its highest in 2021. From 2015 to 21, fatal overdose involving psychostimulants increased 144%. Additionally, the median age at death in 2021 was 46 years for a fatal overdose involving psychostimulants, which contrasts to what we talked about in the last slide. Moving on to the next data source, we will now look at non-fatal opioid overdoses in Clark County in 2021 via EMS data linked with hospital discharge data. The median age for a non-fatal opioid overdose in 2021 for men was 42 years. For women, it was 49 years. So looking at the figure to the right, the highest frequencies of non-fatal opioid overdoses in 2021 occurred in April and in May. The top zip codes in Clark County with the highest frequency of non-fatal opioid overdose events in 2021 include 89101, 89119, 89109, 89121, and then 89102. And all the zip codes that I've just mentioned are in the central Las Vegas Valley, including the downtown and the strip areas. Just like the last slide, we are still looking at non-fatal opioid overdoses in Clark County in 2021. However, we are now looking at all of the data in the form of a heat map. So this is a heat map of non-fatal opioid overdoses throughout the entirety of 2021. As we can see, the red areas of the heat map include the downtown and the strip areas. So that's where we see the most frequencies occurring. Moving on to the last data source that I will be discussing, emergency department discharge data. So emergency department data, along with the previous data sources discussed, can provide critical information to this rapidly shifting crisis. The figure to the left displays the number of emergency department visits due to poisoning by any opioid in Clark County from 2016 to 2020. So from 2019 to 2020, emergency department visits due to poisoning by any opioid increased markedly. Median age for the emergency department visits due to opioid poisoning in 2020 was 38 years for men and then 41 years for women. The implications of these data that I've provided over the past 5 minutes do support evidence-based prevention and response efforts focused on polysubstance use, and that these efforts must be adapted to address the changing drug overdose epidemic. So that's all the information that I wanted to share. So I do appreciate everyone's attention. So thank you, everyone.
Thank you so much, Mr. DeLisi. I appreciate that that context. I was thinking during the overview that Ms. Morgan shared, I was wondering how much of an impact was split between our urban areas and our rural areas. So that was super helpful. Okay, we have, Kyra, I'm not seeing your slide again now, so I don't remember who on that is next, but whoever is next to participate, please. It looks like Sean Thomas is up next. Go ahead and please proceed when you are ready.
Morning, Chair Peters and members of the committee. My name is Sean Thomas, and I'm the opioid epidemiologist and surveillance coordinator for the Nevada Overdose Data to Action team within the Trudy Larson Institute for Health Impact and Equity within the School of Public Health at the University of Nevada, Reno. And today I'll talk briefly about recent drug overdose trends in Washoe County. Next slide, please. So drug overdose deaths have been on the rise in Washoe County throughout the past decade and have only continued to increase, following suit with what Kyra showed earlier with drug-related deaths statewide. The figure here shows the rates of drug-related and opioid-related overdose deaths among residents in Washoe County by year for the past 3 years. Please note that 2021 is still preliminary and is subject to change. However, it does appear that opioid-related overdose deaths may match or even exceed those from 2020. Next slide, please. For this slide and all that preceded, we use data from the EMS platform Image Trend, which collects data from EMS, fire, trauma, and emergency preparedness. We use the system to identify suspected non-fatal opioid overdose, which is pictured by month in 2021. As you can see from figure 2, it has fluctuated throughout the year, reaching a high during the summer months. One thing to note is due to updates to records over time, the most recent months may not be entirely complete. And additionally, I wanted to also mention that in approximately 15% of incidents, the patient was treated but released against medical advice, which is an issue because the EMS personnel believed the person required further treatment, but the patient was unwilling to continue. Next slide, please. So figure 3 here shows the incidence by zip code and both a table and a zoomed in graphic of Washoe County. The top 5 zip codes with the highest number of suspected non-fatal opioid overdose related incidents were 89502, 89512, 89431, 89501, and 89509. They're mostly concentrated in downtown Reno and branches out to Northeast Reno, Hidden Valley, Southwest Reno, and Sparks. Next slide, please. Figure 4 here is showing incidents by age group. The 25 to 34 age group had the highest percentage of incidents, as well as the highest rate of incidents, while the 35 to 44 age group had the second highest percentage and rate. Also not pictured on the slide, but I want to mention as well, 2/3 of incidents were among males. Next slide, please. So figure 5 here shows the percentage of incidents by race and ethnicity. While the chart shows that 44% of incidents were among white, non-Hispanic, the race and ethnicity with the highest rate were those identified as being Black, non-Hispanic. Another thing to note as well is that 1/3 of incidents did not record race or ethnicity, so race and ethnicity data may be underestimated. Next slide, please. I just want to wrap up with a key couple of takeaways. Drug-related and opioid-related overdose deaths have continued to increase in Washoe County, with opioid-related overdose deaths rates expected to exceed 2020 rates. There were 375 suspected non-fatal opioid overdose incidents in Washoe County in 2021, and rates of suspected opioid overdoses were highest among Black, non-Hispanic, and people between the ages of 25 to 34. Although drug overdoses are most common among people identifying as white, it has been people of color who have been seeing the highest rates of suspected overdose and are disproportionately impacted. And then again, wanted to mention as well, the highest zip codes with the highest number of non-fatal opioid overdoses have been concentrated more near the downtown region. So that is all I have. Thank you.
Thank you, Mr. Thomas. I believe we have Dr. Kearns up next for her presentation. Go ahead and proceed when you're ready.
Thank you. Good morning, Chair and committee members. My name is Terry Kearns. With the Nevada Office of the Attorney General. Next slide, please. ODMAP, also known as the Overdose Mapping Application Program, is a program that was originally developed by the Washington, D.C., Baltimore High-Intensity Drug Trafficking Area, also known as HIDTA, and offered free to agencies who are interested in using this program. ODMAP is a program that provides near real-time suspected overdose surveillance data to support public safety and public health efforts in mobilizing an immediate response to a sudden increase or spike in overdose events. Near real time, go ahead and go back. Near real time is defined as within 24 to 72 hours from the suspected events. Suspected overdoses means the information is not fully vetted, as you would find with information such as toxicology results or autopsy results from the medical examiner or coroner's offices. In trying to get that 24 to 72 hour data, you do lose some of the fidelity, but it is a starting point or provides a red flag that there may be something that needs to be addressed further within your community. In our state, the majority of suspected overdose data is from the EMS, electronic medical records. ODMAP data includes 3 data points. Those 3 data points are the location, was the event a fatal or non-fatal overdose, and was naloxone, which is a drug that's used to counteract the effects of an opiate overdose, given, and if so, was it a single dose or multiple doses that were given? In some other states across the United States, such as in New Jersey, they have legislation in which law enforcement enters the information on overdoses. And in that, ODMAP has a feature where case data can be entered, but because the majority of our overdose information in our state is from EMS data, we currently are not using that. And an example would be if law enforcement was on scene and knew that it was a pressed pill or knew that it was heroin, they could enter that information, which we're not always getting currently. Next slide. In the next few slides, I'm going to show you some of the screenshots directly from ODMAP. This first slide shows you typically when you pull it up, you will get information from all over the United States, but I've filtered this down to the information on overdoses, suspected overdoses from our state from January 1st of 2022 to February 8th of 2022. As you can see, the number of suspected overdoses pops up. There were 631. The number of suspected fatal overdoses, which was 19, and then the number of times naloxone was provided at 234. The dots on the screen are color coded, and they show that general location where the suspected overdoses occurred. And they color coded for fatal or non-fatal. Was naloxone given as a single dose, a multiple dose, or no naloxone? The next slide illustrates the ability to provide graphically the data on overdoses. You can see we can look at overdoses by type, and that's that color coding I talked about on non-fatal, naloxone, and so on. We can look at day of week, the hour of day, suspected overdoses that occurred per day, suspected overdoses that occurred per month, and we can look at county and state line charts to see if we are having, for example, a rash of overdoses that have occurred just across 2 counties where you may not have realized that otherwise. So that is how we can look at the data from some of these graphs. Next slide just shows an example if we pull up the day of week that the overdoses occurred. And next slide. As I mentioned, ODMAP is a starting point. There's additional work that would need to be done to determine if a spike in overdoses did actually occur, which brings me to the next point that through the state opioid response grant, each county developed a community overdose spike response plan. The plan will look different for each county, but it was typically a collaboration of public health, law enforcement, fire, EMS, community coalitions, and others as determined by each of the counties. A couple of our counties have taken it to the point of exercising their community overdose spike response plans. As mentioned before, the more real time and the limited data that is collected in ODMAP, we do not have as accurate of information, but it is meant to signal that there could be something happening and a county should look at their community response plan to determine who should be doing what. And a few examples are if there's a spike in a county, law enforcement will want to try to get those drugs causing the overdoses off the streets. Public health and the community coalitions may want to start targeted outreach and harm reduction efforts such as naloxone distribution. This is just a brief overview of ODMAP, and I'll now turn the presentation over to Elise Monroy.
Thank you so much, Dr. Kearns. Please go ahead, Ms. Monroy.
Thank you, Chair. Hello, my name is Elise Monroy, and I'm the Overdose Data to Action Program Manager. I'm here to provide a wrap-up of the data presentations and to discuss some of the existing surveillance gaps. Next slide. So from these presentations, we can see that emergency department encounters from drug poisonings continue to rise. In 2021, deaths by methamphetamine, fentanyl, benzodiazepines, and prescription opioids surged. We also see that people of color and youth are being disproportionately impacted by use and overdose, and polysubstance use and exposure continues to complicate prevention and intervention efforts in the state. On a positive note, we can see from Terry's slides and also from the Attorney General's comments that in recent years, Nevada has developed the ability to collect near real-time information on suspected overdose instances, as well as developed communication and response mechanisms to notify communities of red flags or to notify them that they may be at potential risk for overdose spike or cluster events. While public health in Nevada can get information about suspected events quickly, we don't have a system that allows for timely confirmation of substances that are causing harm in communities. Next slide. At present, Nevada can report on suspected non-fatal overdose and drug use encounters to the emergency department and to EMS, and this is what is used to inform the state's overdose morbidity. Then we wait for the post-mortem tox to confirm the substances that are causing harm and increasing the state's mortality rates. Nevada needs a surveillance system that is both timely and confirmatory to best inform public health prevention and intervention initiatives. In order to get to a system that is both timely or quick and confirmatory, there are a couple gaps in public health's ability to do biosurveillance of the substances that are causing harm. Next slide. Currently, Nevada depends on a limited set of data to inform what the state's level of risk is. This presents challenges for implementing appropriate and timely prevention and intervention programs. At this time, Nevada gets confirmatory tox data about what is in the drug supply from the post-mortem exam. This is reported in alignment with CDC guidelines with a 6 to 9 month lag. So by the time that public health has reported on their data or law enforcement has reported on their data, the drug supply and overdose landscape will have inevitably changed. Waiting for mortality data to tell us what is actively killing people is not a good public health strategy. Next slide. So how do we get to a system that is both quick and confirmatory? First, we need to start by increasing the quantity and the quality of biosurveillance that is done on the drug supply. And to do this, we can go upstream from the post-mortem tox, and this can be done through anti-mortem testing or drug seizure testing or toxicology. So anti-mortem testing is testing that is done before death. So an example of this would be like DUI panels or blood or urine screens done in a hospital. The Minnesota OD2A program has a pilot where they are actually using excess urine drug screen pulled from patients that come in on a suspected overdose. That surveillance sample specimen is then sent to the state public health lab for identification of fentanyl. A drug lab in a neighboring state has reported to the Nevada OD2A program that they're using their DUI data to inform their prevention efforts. The lab reported that they have been stunned by the number of people that are driving under the influence of fentanyl. Another example of an upstream touch point to assess what is in the drug supply would be testing on syringes returned to syringe service points. The Washington, D.C. Crime Lab is actually doing this type of testing and reporting the information to inform public health. In all of these instances, the data that is collected as a result of these tests is being shared with stakeholders and public health to inform community risk. Another example of upstream testing would be wastewater monitoring. Innovative work has been done in Nevada on wastewater testing for COVID, but other states have been using wastewater testing to monitor and inform what's in the drug supply. And finally, data and information gleaned from seized drug testing is another way that public health programs in other states are informing their work. Next slide. The OD2A program is currently working on a needs assessment to kind of understand the state's capacity for testing and biosurveillance of the drug supply to inform risk. So in our preliminary findings, we have identified a few critical issues that may be impacting Nevada's ability to drive to a quick and confirmatory surveillance system. First, Nevada is one of only 2 states with no statewide crime lab. Nevada has 3 labs that serve each region, but each of these labs work independently. So testing panels and analysis is not always standardized. This means that the labs may be using and reporting out on different testing protocols. So in 2020, the Nevada Office of Traffic Safety actually published a gaps analysis on the state's current forensic toxicology lab. The forensic toxicology labs. The report noted inconsistent testing panels and thresholds across the 3 labs in the state was a significant gap. Specifically, the report notes that the 3 labs use different testing panels and test for different numbers of drugs, ranging from one lab testing for 30 drugs, while we have another lab that's testing for 30. One lab testing for 30 and another lab testing for 60. The report also noted that there is a difference in the cutoff values used to distinguish positive and negative results, and this cutoff inconsistency also impacts interpretation of results. So while standardizing analysis with these forensic labs will help to ensure fair treatment of all drivers and ensure the state knows which drugs are causing impairment for forensic purposes, it can also help to better inform public health's prevention and intervention efforts. Next, Nevada's existing crime labs are forensic in nature. Through our needs assessment research and work with labs, we understand that the role forensic labs play in the current system is to use science for the purpose of criminal proceedings, not for public health surveillance and not to inform community risk. Currently, there are a limited number of data sharing agreements in place between crime labs, law enforcement, and public health or prevention partners. We know that some of our local prevention and overdose spike response stakeholders enjoy informal information sharing relationships with their local law enforcement, but these agreements are largely relationship and personnel driven, and this is inconsistent with building a sustainable system. And finally, through our work on the needs assessment, we have heard that many of the drugs seized in Nevada are actually not even tested. Seized drugs are tested if and when a case goes to trial. So we have heard that this could be a result of not enough lab capacity or funding. So if seized drugs are tested in Nevada, that data is sent to the National Forensic Lab Information System, or NIFLS. NIFLS data is reported quarterly. So while our program has not had a chance to take a deep dive into how local crime labs are funded, we did find that forensic testing is at least in part supported through a county general fund. NRS 457.575 requires court fees to be levied to pay for controlled substance analysis. If a county can only recoup the cost of analysis when court fees are levied, that may result in limited testing resources. Next slide. So some recommendations to address these critical issues include developing a statewide crime lab that allows for standardized forensic testing, as well as a statewide lab that has the capacity to do surveillance sample testing to inform public health risk. Next, the state should look to developing standardized data sharing agreements and mechanisms statewide. And finally, examine the funding formulas or mechanisms that may be impacting testing capacity in Nevada. It's not inevitable that deaths by opioid, fentanyl, and stimulants have to continue to rise. Implementation of harm reduction strategies and public health interventions can be done to curb deaths. However, these strategies should be informed by timely confirmatory data. And if public health in Nevada has to continue to rely on a surveillance system dependent on death data to tell us what's killing people, the state may struggle to get ahead of these deaths. And with that, that concludes this panel's presentation. Are there any questions?
Thank you so much, Ms. Monroy. Yes, I believe we have a couple of questions from the committee. I'm pulling my list up. I did see Senator Hardy, Assemblyman Ornlicker both have questions, and I have some follow-up as well. So we're gonna, I just want to let the committee know that I have about 10 minutes scheduled for questions. Obviously, this is an important issue, so we may go over that a little bit, but I would encourage, if you are interested in this topic, please take down the names of these folks who presented today, reach out to staff for their contact information if you don't have it, and get in contact with them over the interim to talk about these issues and what we can do. We also have an opportunity to look at some of these recommendations as potential BDRs that come from this committee, but we will do that at a later date. I'm going to go ahead and start with Senator Hardy. Please go ahead with your question.
Thank you, Madam Chair. I was interested in what Kyra was talking about. When we read the newspaper, we keep reading about the school age kids that aren't in school and how we're seeing an increase in mental health issues and drug use. And I didn't see the differentiation of that kind of group, and wondering what we're doing with that particular group. And are we not seeing that kind of drug, alcohol use in our school age kids, or is it just something that isn't as pronounced? Thank you, Madam Chair.
Sure, this is Kyra Morgan for the record, and then I might phone a friend for Dr. Woodard, who I think is also on the call. I didn't prepare data, unfortunately, at an age level, just because I had a 10-minute time crunch and I couldn't fit everything in there that I wanted to fit, but I can surely follow up with that age breakout. I do believe that we've seen increases most specifically in teenage years and early adulthood. So I think last time I looked, it was up through age 30 or something where we saw the most significant increases, but I can follow up with the committee with specific numbers. And then Dr. Woodard, I don't know if you can address, or maybe Elise, on what we're doing for targeted intervention.
This is Dr. Woodard. Are you available? I thought I saw you on the list today.
Hi, good morning, Chair. I'm here. Stephanie Woodard for the record, through you, Chair, to Senator Hardy. We have actually seen a pretty significant increase in indicators that suggest that the amount of youth behavioral health has increased. This includes both substance use as well as mental health conditions. So as Kyra was mentioning, the core group are typically adolescents as well as young adults. And we can certainly provide some additional data for this group if that is needed.
That would be appreciated, Dr. Woodard. Thank you so much. If you wouldn't mind working with staff on getting us that information, we can pass that around to the committee. Assemblyman Ortlicker, please go ahead with your question.
Thank you, Madam Chair, and thank you, presenters. This data is very illuminating, and I appreciate you presenting it to us. One question I had was helpful when you gave us the absolute amounts and then the relative amounts that some populations have higher proportionate drug use. And do you have a urban-rural comparison? Obviously, there are going to be many more cases as you in Clark and Washoe, but do the rurals, are they hitting proportionally more, less, the same? Do you have that information?
This is Kyra Morgan. For the record, we do have that information. I just don't have it again in this presentation, but I will add that to my follow-up for the group. And just a reminder, we do have most of that online, so I'll be able to pull that together quickly as a follow-up to this.
Thank you.
Thank you so much. As Dr. Titus has a question as well. Please go ahead.
Great. Thank you, Madam Chair. Thank you for the presentation. Scary data. I've been on the HHS committee now 4 terms and the interim committee 4 terms. And I just, for a while we were making a difference. The numbers were going down, and this data is pretty alarming that it's going back up again. I need some clarification. We can send it to all of us maybe afterwards. You did briefly mention Narcan, and that on the OD maps, you can chart whether or not Narcan was given and how many times. I'd be interested in seeing kind of a breakdown and number from. I quickly did some math, and it looked like, at least on the one chart you had, there was probably 520 deaths prevented because Narcan was used. And I know I know both Dr. Hardy and myself had supported having Narcan in schools, certainly allowing our police force to use it, allowing it in businesses. And I was just wondering if we have any breakdown of where this Narcan is being used, what the actual numbers of prescriptions, and if you have any of that information. And if so, could you send that to us?
So
I think go ahead.
I'm sorry, Assemblywoman. This is Elise Monroy with the OD2A program. So I believe the state's opioid response grant collects that information. So I will coordinate with the SOR program on following up with the committee.
Great, because I would really like to know if it's been given in a store, or how often was it the police that gave it versus EMS, because EMS should be given it, but we really expanded access to that. We actually put it in bags when we prescribe medication. And then that's the next segue I have for, and also, by the way, I really appreciate you bringing up the state crime lab, because I've met with many sheriffs. I represent multiple counties, and to a sheriff, they all say they would like to have the crime lab. But what the sheriff is also saying is a concern to me, because we have restricted over my sessions doctors from prescribing. We've reined in our, because we were the bad folks prescribing too many narcotics, and we really regulated our prescriptions. And I know our Board of Pharmacy will be addressing some of this later. And then our Attorney General sued the bad pharmaceutical companies because they created these drugs that got everybody addicted. So we've done all those two things, but what I'm not hearing, what I'm hearing actually, is that we are having still more drugs, and despite those efforts. And what the sheriffs that I've met with have said is that they're really concerned. They've seen almost a 4-fold increase in illegal drugs in the rural counties, and their belief is because of open borders, that more drugs are coming across into our state from, it doesn't matter what country, it doesn't matter what state, but they're coming into Nevada. And so is anybody addressing where these drugs are coming from, or are we going to hear that later today?
So this is Elise Monroy for the record. I will take that one. I would think that maybe Haida will be addressing that later, or the law enforcement presentation. From a public health perspective, we get limited data from law enforcement related to drug seizures. And like I mentioned, local prevention and spike response agencies have really great informal information sharing relationships with their local law enforcement. I know that we worked closely with Douglas County on their spike response, and their law enforcement works really closely with their coalition, but it's very relationship driven. So we don't have a lot of information about what the drug supply looks like in Nevada. Kind of to my points, in order for us to really get ahead of what's in the drug supply and to inform prevention and intervention efforts, we have to know what's in the drug supply. And unfortunately, we currently have to wait until we have death data to tell us what people are dying from. So in effort to kind of increase awareness about what's in the drug supply and what substances are causing harm could help to help public health do more informed strategies.
Thank you, because I really think communication across all departments is so important. So thank you for what you're doing, and thank you, Madam Chair, for the questions.
Thank you, Dr. Titus, and thank you, Ms. Monroy. I don't see any other questions from my committee, but I have a couple of questions, but I will take most of mine offline. The one that I would like to ask, though, is to Ms. Morgan. You had some indicators collected for diagnoses of folks who come in with drugs in their system. And I wanted to know whether we're collecting information on whether that diagnosis is for behavioral, mental, or physical problems when they are presented in the hospital and in that EMS data. And if you have any breakdown of that as percentages of the cases that we're seeing in those diagnoses as they pertain to drug use.
Yeah, this is Tyra Morgan for the record. That's a really interesting and great question. The slides that I prepared for this meeting are very high level. So those are truly anyone in an emergency department setting who during that encounter, it was indicated in their bill that they either had drug use or abuse. It was not limited in any way to behavioral health or mental health diagnoses, but we can absolutely pull that information by looking at other diagnosis codes on those billing claims. And I can follow up with that information to the committee.
That would be great. Thank you so much. I think that would really help us understand what kind of our limitations are in those emergency rooms, and where we can focus some energy for this, that piece. All right. With that, we're going to go ahead and move on to our next agenda item, which we're taking out of order because we have Dr. Terry Kearns with us right now. We're going to move on to agenda item 14, which is an update on Assembly Bill 374 from the 2021 legislative session. This establishes the statewide substance use response working group. Ms. Kern, please, or Dr. Kern, please go ahead whenever you are ready.
Great, thank you. Let me share my screen here. I wanted to talk to you today about Assembly Bill 374 that establishes a statewide substance use response working group, also known as the SURGE, which you heard about from Attorney General Ford out of the Attorney General's office. If you look at the bottom of this slide, you can see the references on where to find Assembly Bill 374 on the Nellis home site. And you can also find information on the SURGE on the AG's website as well. If you go to the AG's website, scroll down to committees and boards, and then that will take you to where you scrolled over to the substance use response working group. One thing that is significant about AB 374 is this bill deals with all substances and substance use disorders, as opposed to just focusing on opiates and opioid use disorders. As you've heard and we'll hear more, polysubstance use and misuse and other substance use and misuse is at high levels in the US and in our state. There were 18 members that were appointed to the SURGE that include legislators, people who work in the field of substance use disorders, people who work with prevention and harm reduction programs, people who use drugs or family members of those who use drugs, law enforcement, representatives of urban, rural, and frontier counties, and representatives from our school. The membership is Chelsea Cheatham, who's a program manager with Track B Exchange, which is our safe syringe program. She represents a program for representing harm reduction caused by substance misuse. Barbara Collins is a principal of Mission High School in Clark County School District. She represents the school district. Leslie Dixon, medical director for Center for Behavioral Health. She's a provider of healthcare with expertise in medicine for the treatment of substance use disorders. Fabian Donate, state senator, District 10, state majority leader appointee. General Ford from the Attorney General's office. Shayla Holmes, the director of Lyon County Human Services, a representative of the local government entity that provides or oversees a provision of human services in a county whose population is less than 100,000. Jeffrey Iverson, director of Shine a Light Foundation and Freedom House, one person who is in recovery from substance use disorder. Jessica Johnson, senior health educator from Southern Nevada Health District, a representative of local government that provides or oversees a provision of human services in a county whose population is 700,000 or more. Lisa Lee, Human Services Program Specialist, Washoe County Human Services Agency. She is a representative of local government that provides or oversees provision of human services in a county of a population of 100,000 or more, but less than 700,000. Debbie Nadler, co-founder Moms Against Drugs, one advocate for persons who have substance use disorder or family members of such. Christine Payson, representative from the Nevada Sheriff and Chiefs Association, the law enforcement representative. Eric Schoen, executive director of Community Chest, Inc., one representative of a substance use disorder prevention coalition. Steve Schell, vice president, behavioral health, Renown Health, a representative of a hospital. Claire Thomas, state assemblywoman, District 17, the Nevada Assembly Speaker appointee. Danny Thomas, executive director of Ridge House, one person who provides services related to the treatment of substance use disorders, Jill Tolles, State Assemblywoman, District 25, Nevada Assembly Minority Leader appointee, and Dr. Stephanie Woodard, Senior Advisor for Behavioral Health to DHHS Director appointee. AB 374 does a lot. There are 16 items labeled A through Q in the legislation that the surge is to address. And straight from the legislation, this bill requires the surge to comprehensively review various aspects of substance misuse and substance use disorders and programs and activities to combat substance misuse and substance use disorders in our state. The activities include assessing, studying, examining, evaluating, and then making recommendations concerning substance use and misuse based on these findings. The surge works in conjunction with Senate Bill 390's Advisory Committee for a Resilient Nevada, ACRN, which you've already heard about, and you will hear more on later. Recommendations from the surge and the ACRN assist with how the funds from the Fund for a Resilient Nevada that was established out of SB 390 are directed. As you heard from General Ford, a major source of funds for the Fund for a Resilient Nevada come from the opioid litigation settlement funds. Part of the requirement of AB 374 is for the surge to produce an annual report, which was provided as part of the attachments for the committee meeting today and can also be found on the AG's website that I referenced earlier. The report for this year outlines the appointment of the 18 members who I told you about, discusses the first and only meeting that was held in 2021 on November 16th of 2021. Much of that first meeting was laying out the form and structure of the surge to include electing General Ford as the chair and Assemblywoman Tolles as the vice chair, the adoption of the bylaws, and setting up the priorities for 2022. This included setting up meetings in 2022 and being briefed on the state needs assessment, the state plan, and state and local funding of programs to address substance misuse and substance use disorders that will all be provided through DHHS. The formation of subcommittees based on the priorities discussed in the November 2021 meeting were outlined. The framework for the 3 subcommittees that are being formed are 1, prevention, 2, treatment and recovery, and 3, response. The 16 items that were laid out in AB 374 to be addressed by the surge were used as guidelines for these 3 subcommittees. There were some items that are overarching and will be addressed by all subcommittees, such as special populations. And special populations defined in AB 374 is veterans, elderly persons, and youth. It's the first group. The second group is persons who are incarcerated, persons who have committed nonviolent crimes primarily driven by a substance use disorder, and other persons involved in the criminal justice or the juvenile justice system. Pregnant women and parents of dependent children are the third group. The fourth group, lesbian, gay, bisexual, transgender, and questioning persons. The fifth group, persons who use intravenous drugs. The sixth group, children who are involved with the child welfare system. And the seventh group is other populations disproportionately impacted by substance use disorders. Another overarching item that will be addressed by each of the 3 subcommittees is data and information sharing. The surge will meet quarterly in 2022, and the subcommittees will meet monthly, and then the subcommittees will report back to the larger surge. I invite everyone to read the 2021 surge annual report that I provided. It provides a much more in-depth review of the surge's 2021 activities and the priorities for 2022. And this will conclude my overview of AB 374 and the 2021 activities of the surge. And I welcome any questions anyone may have.
Thank you so much, Dr. Kearns. Are there any questions from my committee? I'm not seeing hands raised, so please unmute yourself if you have any questions. I'm not seeing any questions coming from the committee. I'm looking forward to seeing, so you did say there has been 1 meeting so far. Do you have additional meetings scheduled
There was one meeting in 2021, that was November 16th. There was also a meeting in 2022, that was January 19th. And we have another meeting scheduled on March 9th. And then we'll look to June to schedule the next one.
Great, great. Well, we look forward to updates from your meeting and how things are coming through on what your recommendations come out of those meetings. And hopefully we'll get to hear from you later on those.
Thank you.
Thank you so much.
Chair Peters, you're muted.
Thank you. We're going to go ahead and go back into our regularly scheduled agenda item. We're going to move on to item number 6, which is an overview of opioid and stimulant prescribing patterns in Nevada. And I hope some of this information gets at some of the questions that were asked during the previous presentation. I have Dr. Friedman on my list as potentially the first person opening this, but I'm going to go ahead and pass it off to our presenters and let you guys drive this further. We will wait until after the presentations to ask questions. Please proceed when you are ready.
Thank you, Chair Peters and members of the committee. I'm Darla Zarley with the Nevada State Board of Pharmacy Prescription Monitoring Program. Next slide, please. First, I want to provide you with an overview of the Nevada Prescription Monitoring Program. Sorry, I'm really nervous. It was established in 1997 and co-administered by the State Board of Pharmacy and the Nevada Division of Investigation. It is currently housed at the State Board of Pharmacy. It was originally designed to identify potential doctor shoppers. However, the role has expanded to help identify inappropriate prescribing and prescription forgeries. It's a computerized program to track all controlled substance prescriptions dispensed to patients in Nevada. Pharmacies and dispensing practitioners transmit their prescription data to us on a daily basis. The prescription monitoring program is a very important tool to assist practitioners in making a clinical decision on whether or not to prescribe a controlled substance to a patient. Next slide, please. There are 2 major bills that have been passed to fight the opioid epidemic: Assembly Bill 474 in the 2017 session and Assembly Bill 239 in the 2019 session. Next slide, please. One goal of AB 474 is to prioritize patient safety and inform patients of the risks of taking an opiate. It was designed to create an open dialogue between the patient and the provider to ensure prescribing a controlled substance is medically necessary and appropriate. Another goal was to prevent addiction and misuse of controlled substances. This was accomplished by requiring a prescriber to check the patient's PMP prior to prescribing a prescription, and then every 90 days thereafter if they're going to continue that course of treatment. It also established guidelines for writing an initial controlled substance prescription. The initial prescription may not exceed a 14-day supply or daily 90 MME for an opiate-naive patient. An informed consent was required from the patient, between the patient and the provider. It required a patient medication agreement and a patient risk assessment if the treatment was going to last more than 90 or 30 days. And it required a risk of abuse assessment if the treatment was greater than 90 days. Next slide, please. Assembly Bill 239, which was passed in the 2019 legislative session, provided further clarification and guidance on AB 474. The patient risk assessment was limited to the relevant medical history of the patient's pain, not the entire patient history. The initial prescribing guidelines were now allowed to exceed a 14-day supply or daily 90 MME if the practitioner deemed that it was medically necessary. There were also some concerns from practitioners that hospice patients were not getting treatment in a timely fashion. So there was an exemption made for hospice, palliative care, oncology, and sickle cell prescriptions. The practitioner was not required to check the PMP prior to prescribing. However, they were required to check the PMP as soon as possible and at least 90 days thereafter if they were going to continue the course of treatment. They were not required to perform a patient risk assessment, enter into a patient medication agreement, or adhere to the initial day supply or daily MME. It also defined in statute course of treatment and acute pain. Next slide, please. What you see here is the number of patient queries ran by doctors from 2014 to 2021. And what this shows is there's an increased usage of the prescription monitoring program, which is essential in assisting practitioners with prescribing appropriately and preventing misuse and abuse of controlled substances. Next slide, please. And now I'm going to turn it over to Kyra to go over prescribing patterns.
Thanks, Darla. This is Kyra Morgan again, but Chair Peters, would you like to take questions now, or do you want me to keep powering through?
Let's go ahead and make it through the presentations, and then we will ask questions at the end.
Okay, perfect. So again, Kyra Morgan, State Biostatistician for the Department of Health and Human Services. I'm going to touch just briefly on opioid prescribing patterns, and then Dr. Beth Slamowitz, our Senior Policy Advisor on Pharmacy, is also going to chime in on prescribing policies within fee-for-service Medicaid. So here we're looking at a couple of maps showing prescribing patterns per capita, and you can see national comparisons as well as kind of how that progress has been made over time. In 2020, Nevada providers wrote 47.4 opioid prescriptions for every 100 people, compared to an average US rate of 43.4 prescriptions. And although Nevada is still slightly higher than the national average, we have observed a decline from 73 opioid prescriptions for every 100 persons in 2017, which is a 35% decrease. These maps are actually super interesting and go back in time to 2008, and you can watch them kind of dynamically change as the opioid pandemic has progressed, and that's all available at the link here, which is sourced as the US opioid dispensing rate maps provided by the CDC Injury Center. I also wanted to take this time to let the committee know that we do maintain all of the data I'm about to go over, also public facing on a dashboard that's updated monthly, the Nevada Prescription Drug Monitoring Program dashboard, in case anyone's interested in monitoring this after the meeting. Here's a chart that's looking at opioid prescription counts and rates per 100 by month from 2017 through 2021. Obviously, we see significant decline over that period in the magnitude of 44%. We also see significant decline in the number of individuals who are co-prescribed opioids and benzodiazepines during the same month, decreased even more significantly by 68% in Nevada. Here I'm looking at opioid prescription counts and rates by days supply, so how many days were supplied in those prescriptions. And I included some detailed data from 2017 and 2021 that you can reference, but I really just wanted to make some high-level conclusions, and that is that we have seen opioid prescribing rates decrease across all supply volumes over this time frame. More specifically, for prescriptions with less than 30 days supply, we observed a 52% decrease. We saw a 36% decrease in prescriptions with 30 to 90 days supply, and then a 55% decrease in prescriptions with more than 90 days supply. We can also look at this using a morphine milligram equivalent, or MME. Potency can be compared across the spectrum of opioid drugs using a conversion factor to an MME. Essentially, by converting different opioids to a standard unit of measure, a prescriber is more able to assess a patient's potential risk for overdose related to dosing. And Nevada observed decreasing trends across all MMEs from January 2017 to December of 2021. The largest declines were observed in patients receiving the highest level of MME. So patients who received greater than 90 MMEs per month decreased by 53%. The number of patients who received 50 to 90 MMEs per month decreased by 49%. And patients who received less than 50 MMEs per month decreased by 28%. I do just have one more slide, but really it's for reference, and it gives details at a county level for those who are interested, but I'm not going to go over this in great detail. With that, I think I will hand it over to Dr. Slamowitz to talk about Nevada Medicaid opioid prescribing policies.
Thank you, Kyra. Sorry, Chair Peters and the rest of the members of the committee. My name is Beth Slamowitz, and I am the Senior Policy Advisor on Pharmacy for the Department of Health and Human Services. I'm just going to do a really high-level overview of current prescribing policies within fee-for-service Medicaid. The first bullet point there, just for reference, Chapter 1200 of the Medicaid Services Manual does set the guidelines and limitations regarding coverage for prescription drugs for Medicaid. So the link is there in case anyone is interested in exploring any further. A few of the high-level policies that are currently effective for fee-for-service Medicaid, we do have limitations on early refills for controlled substances. Currently, 90% of the controlled substance has to be used before a refill will be authorized. We also have policies on transdermal fentanyl, long-acting narcotics, and both of those locations within the Medicaid Services Manual chapter are identified for further review. Lastly, we have a policy on opioids, opioid-containing cough preparations, and opioids prescribed to under age 18. What I did want to point out here is that when this policy was put in place, we were anticipating the passage of AB 474, but did put in requirements that were a little more restrictive than what AB 474 did pass. And so the limitations on the Medicaid fee-for-service policy is for prescriptions of 60 milligram morphine equivalents or less per day, as well as for a 7-day initial prescription versus the 14 and 90 morphine milliequivalents that exist within NRS for AB 474. Prior authorization is not required for under age 18 if the initial prescription is for 3 days or less. And there is an exceptions policy to allow for treatment of cancer-related pain, post-surgery that has greater than a 3-month recovery time, palliative care, long-term care, HIV and AIDS, or in consultation with a pain specialist. For the opioid-containing cough preparation, there's also an age limitation of 18 years or older. We did also implement a codeine and tramadol for children policy as well. The reference for that policy is indicated here on the slide. Lastly, what I just wanted to mention is that when the opioid policy was implemented in May of 2017, prior to the passage of AB 474, there were roughly just over 19,000 opioid prescription claims per month that we saw. The average prescription claims per month in 2021 was just over 11,000. So we have seen a decrease on average of about 6% year over year. So that concludes my one slide presentation. So I'm going to go ahead and stop there and see if there's any questions from the committee.
Thank you so much. I appreciate your presentations today. I'm looking, it looks like Senator Hardy, Dr. Hardy has a question, and we'll go from there. Go ahead, Dr. Hardy.
Thank you, Madam Chair. As I've looked at graphs before, we've done a wonderful job decreasing the amount of prescription opioids and benzodiazepines and both of them together. So I think we're doing what we can. And as I look at the graphs of opioid deaths, overdose deaths, it seems to be more heroin and fentanyl that aren't prescription. So my simple question is, have we actually decreased overdose deaths at the same time we've decreased prescription opioid amounts given?
This is Kyra Morgan for the record. We did decrease opioid overdose deaths until a point, and I think we saw those unfortunately start climbing again in 2020 and 2021.
So have we actually had fewer deaths now than we did before? Now.
Let me follow up with some detailed information on that so that I can make sure I'm comparing the same timeframes and things like that, if that's okay.
Yeah, thank you.
Dr. Hardy, I also was remiss. We have a couple more, one or more folks to present still on this issue, so that may answer some of your questions. And I saw you, Dr. Ornlicker. We're going to go ahead and hold off on questions till we're done with the presentation. That was my fault. I apologize. So I believe that Dr. Friedman is the next up for presentations. And then after this, there may be one more, and I'm going to let you guys let me know and we'll take questions on the presentation after that.
Thank you, Chair Peters. I believe I'm the last presentation in this group.
Okay, thank you.
And my name is Sarah Friedman. I'm an assistant professor at UNR in the School of Public Health, and I will be sharing preliminary results from a NIDA-funded research study of the effect of AB 474 on opioid prescriptions among Medicaid pain patients. Slide. We studied non-cancer primary care patients age 18 to 64 who used Medicaid between 2016 and 2019 in Nevada or Colorado. The slides that follow focus on the Nevada data, but data from Colorado are included in this presentation for your reference in the appendix. This next slide shows the outcomes that we studied, as well as the subset of patients among which we studied each outcome, which are in blue text. For example, we examined days supply among patients with acute conditions. I'll note that several of our outcomes are based on the current CDC opioid prescribing guidelines rather than AB 474 because our research was interested in whether the law increased receipt of guideline concordant care. The outcomes not mandated by the law include the 50 MME threshold, the 7 days supply threshold, although as Dr. Samowitz just mentioned, that was required by the Nevada Medicaid policy, immediate release preparations, urine drug testing, and use of alternative pain therapies, including physical therapy. Next slide, please. Our results were largely in accordance with the findings for the outcomes that we both looked at. So we observed decreases in the proportion of patients with initial opioid prescriptions over both 50 and 90 MME, as well as decreases in days supply over 7. We also observed desired decreases in co-prescribed opioids and benzodiazepines, and desired increases in urine drug testing and physical therapy. The slight but statistically significant decreases in immediate release preparations that we observed did go against the CDC guidelines. The next 2 slides help us see the magnitudes of the changes in 2 of our outcomes of interest. This first slide shows the trend in initial prescriptions with MME over 50. The average proportion of patient months with this outcome after the law decreased 10 percentage points from 19% to 9%. We saw substantial decreases both in the months immediately after the law and throughout the rest of 2018. Our adjusted analyses, where we controlled for patient characteristics, time, and state, found strikingly similar results. The proportion of opioid-naive patients getting prescriptions over this threshold would have been substantially higher, about 20% in January of 2019, if the law had not been passed, compared to what it was given that it was passed, which was about 9%. Next slide, please. Another notable finding was in co-prescribing opioids and benzodiazepines. The average proportion with this outcome after the law decreased 7 percentage points from 21% to 14%. There was not a significant change in this outcome in the months immediately following the law, but after the law, the time trend decreased at a faster rate. Our adjusted analysis found that the proportion of patients with co-prescribed medications would have been substantially higher, about 17% in January 2019, if the law had not been passed, compared to what it was, which was about 13%. On the next slide, we've collected some related evidence from other states, finding results that are generally consistent with what we found here in Nevada, seeing decreases in dosages and days supply. I won't go through this slide in detail, but I'll leave it here for your reference. And then finally here on the next slide is my contact information. We've also learned that this committee may be interested in prescription stimulants, which we haven't looked at in this study, but going forward, we would be interested in investigating trends in stimulants in the Medicaid claims data if that would be of interest. Thank you so much for your attention.
Thank you so much, Dr. Friedman, and all of the presenters today. Okay, I'm going to go back to questions. Senator Hardy, did you have a follow-up on your question related to decreasing in death.
Thank you, Madam Chair. The question would be, have we actually decreased the number or the rate or the average or the number of deaths by opioids? Because my theory is we've done a great job decreasing prescriptions of opioids, and we have had people turn to fentanyl from the corner, not the corner drugstore, but the corner virtual store. And so I think we've seen heroin go up and we've seen fentanyl go up. At the same time, we've seen prescription rates go down. So my question would be, are we saving more people, or are we putting them on the street corner getting a more risky form of fentanyl, more risky form of an opioid, and therefore we're still having a rate of death that may or may not be improved? Question mark, question mark.
And this is Kyra Morgan for the record. I'd like to follow up with a detailed response on that. I'm looking at our opioid dashboard now, and I have some numbers in front of me, but I think it would do the committee more justice if I could provide something a little more thoughtful as a follow-up to this meeting.
I think that would be great. Thank you so much for offering the follow-up. If you could work with staff on making sure we get that, and we'll get that out to the committee as well. I think it's a good point, Doc Hardy. We're looking at decreasing deaths and we're seeing increasing overdoses, and where can we put in some additional effort to address those? Okay, I have Dr. Hornlicker on my list as the next person with a question. Please go ahead.
Thank you, Madam Chair. I also have an unintended consequences question. My guess is that the decrease in prescribing is good, that we're eliminating inappropriate prescribing, but I know at the time that these bills were passed, there were concerns of practitioners that it would make it harder to prescribe appropriately. And when you did mention that there's been increased use of physical therapy, which suggests to me that we're seeing a good transition from opioid prescribing to more appropriate therapies, but are we seeing any unintended consequences in terms of inadequate use of opioids?
Thank you for your question. I can try to address that, although we're not able to always look at appropriateness of care for every patient for whom claims we examined. It was encouraging to see increased use of physical therapy for patients with joint pain, and we also looked at use of non-opioid pharmaceuticals. We did not see the desired increase in that outcome, which was less encouraging.
Thank you.
A follow-up. Okay, we're good. Thank you so much for that information, Dr. Friedman. Are there any other questions from the committee? I'm looking at my multiple ways of communication, and I don't see any other hands up. Please unmute yourself if I missed you. All right, we're going to go ahead and move on to the next agenda item. Thank you all so much for your presentations today. Our next agenda item is agenda item 7, the drug landscape. High intensity drug trafficking areas within Nevada, trends and public health implications. We have Keith Carter here with Nevada High Intensity Drug Trafficking Area for his presentation. There we go. Hello, Mr. Carter. Please proceed when you are ready.
Good morning. First of all, I'd like to thank the committee for inviting me here today to talk about the high intensity drug trafficking program and what we do in terms of what this committee deals with. And just for purposes of an introduction, since it's the first time that I've been here as the director of the statewide program, I'd like to just give you a brief overview of what the high intensity drug trafficking program is. And of course, I want to give a shout out to my comrade, Terry Kearns, who also discussed one of our premier programs, OD MAPS, which was developed through HIDA several years ago and now has gone nationwide. HIDA, as it's called, it's a comprehensive overarching program that has been in the state of Nevada since 2001. We're primarily a law enforcement program. However, recently, in the last few years, we have partnered with the CDC and have created what's called the Overdose Response Strategy. It's a nationwide strategy to address overdoses and partner law enforcement with public health. Many of the people on today's committee that have talked are very familiar to me. They're people that my program and my personnel deal with frequently. And so it has been a collaboration that really has helped, I think, law enforcement realize that in reality, we could be doing more to help our public health situation. Today, I've been asked to talk about our drug threats, and so I'm going to take it from a little bit of a different view than what we've heard today, and also understand that it can be complicated to really, understand what our drug threats are in our state. There's a lot of information to decipher, and it depends on what your needs are and how deep you want to look through that information. And the best example I can give of that is in law enforcement, you have to consider that primarily law enforcement deals with preliminary information. They respond to a situation, they take action, they move very quickly and move on to the next situation. And so sometimes the information that law enforcement collects is subject to change as it's merged with long-term data research. And that's one of the areas that we rely on our public health partners is to do that long-term research. And a lot of the information you heard today, we utilize that to develop a total threat picture. But over and above that, the information that we collect in developing what are the drug threats to our community, and I'm just going to go through some of those so you kind of understand that we really take a very wide spectrum of information. And first off is investigative data. So we look at our investigations. What are the investigators really investigating? And often that information is in real time. And over a period of time, we may see some of that change. We also survey annually about 2,000 law enforcement personnel in our state. We want to know what it is they're seeing on the streets, what changes they have seen, really what's happening now. We take an extensive view of drug seizures, overdose investigations, as well as overdose trends. And as I said, information from public health and also information from our border. It's important. The border information is important to us because of our proximity to Mexico. It's a barometer of what we may see on the streets. So today, what I'm going to do is just really kind of give you what I call a 30,000 foot view. I'm not going to spend a lot of time on a lot of data because you've already heard most of that. The other aspect is that I'm focused on illegal and illegitimate drugs. That's the area that we deal with, and that's what I'm going to talk about today. Several of the previous presenters talked quite a bit about drug use, and one of the things we hear a lot is polydrug. And I think it's important that the community understand that we do see more polydrug users today than what we have in the past. And by that, I mean, it's individuals. And if you look at the overdose data from some of my colleagues, you'll see where many people who die from overdoses have multiple drugs. In the past, we had drug users who primarily used cocaine or primarily used heroin. But today that has changed quite a bit. And that complicates what it is that we all do. It complicates our prevention. It complicates our investigations, and it complicates our ability to reduce the supply. So I'm going to kind of look at those drugs, those illegal and illegitimate drugs, in what we call a threat order. What is the worst? In our state, meth is by far the worst drug that we have on our street. It has been for many years. It's cost more lives than any other drug. If you look at just Clark County in 2001, because it's a good batch of numbers we can look at and we get the information pretty quickly, almost 900 overdoses and well over 500 of those caused by meth. We see meth in a very pure form on the streets. It's very inexpensive. It's readily available across our entire state. Within the state of Nevada, in 2021, well over 500 pounds of methamphetamine were seized by law enforcement. It's seized in powder, pills. A user smokes meth, snorts meth, and we find it in a pill form. And I want to talk a little bit about the history of meth, and that may help some of the questions on overdoses and have we made a difference. I heard that question from one of the committee members. Back in the 1990s, methamphetamine labs were pervasive. They were all over the state. In Clark County, a methamphetamine lab was discovered every day for several years until our legislature made some changes in our laws that have been very effective. Today, we find very few methamphetamine labs. But what has happened is we have more methamphetamine today than what we had when we had it being manufactured in our own state. And it's a higher quality than what we had manufactured here. So is it an unintended consequence? It may have been. We just don't know. There's too many factors involved, and there's too many. When you look at what's occurred in Mexico in the manufacturing, where all of our meth is manufactured in Mexico and brought to our state, there's been significant changes there. So it's hard to answer that question. Meth is 100% man-made, which complicates our ability to reduce the supply. It's different than other drugs that are grown on plants, and I'll talk about some of those in a little bit. The next drug in our threat order, so to speak, is fentanyl. Fentanyl, we consider fentanyl a very significant threat to our citizens. And the difference with fentanyl and meth is fentanyl in terms of illicit drugs on the streets is relatively new. Began 2014, 2015 for our state, and now it's essentially everywhere, unfortunately. And as several presenters have discussed, fentanyl is a very potent drug. Most of the illegitimate, again, that's the drug I'm talking about, is manufactured in Mexico, transported to our state in either powder form, but primarily in pill form. The pills that we see primarily resemble an Oxy 30 pill, and to a person who is not an expert, they're very difficult to determine the difference. We've seen an increase in fentanyl deaths since the beginning of fentanyl on our streets. We know that there are some drug users that seek out fentanyl, want to use fentanyl, but we also know that there are those that use the drug, and it's probably unintentional. We also know that when it comes to fentanyl, we find drug users that are not your typical drug addict, which adds to our complication in dealing with the situation. We also know from investigating overdose deaths of fentanyl that some of these deaths are instant, where there is no opportunity to use Narcan. We also know that finding fentanyl and interdicting fentanyl for law enforcement is very difficult. Your typical pills are easy to hide. They don't have a lot of odor, and it complicates really the entire situation. Last year, just in Clark County alone, there were well over 100,000 pills seized by law enforcement. So it's on the streets, very easy to get. A pill typically of fentanyl ranges from about $25 to $65, depending on who the drug trafficker is. We also find that our drug traffickers are also poly-drug dealers, in that it's rare to find someone who is only trafficking fentanyl. Normally they have methamphetamine, fentanyl, and a lot of times heroin. Next, we would classify heroin as our next threat. The use of heroin is relatively stable. However, it has not gone down. The price of heroin has remained stable, and again, it remains available on the streets. In Nevada, we see what's called black tar heroin, brown heroin, not the typical white heroin that you might see in Hollywood movies. Heroin's manufactured from a plant. It also comes from South America and Mexico into our state. Cocaine is next on our list. Cocaine, many people believe cocaine is a designer drug, a drug that is not addictive, that they can use cocaine and on Saturday and go to work on Monday. We have obviously a number of overdose deaths from cocaine. Cocaine is very high priced, remains high priced. What is of concern is we have found cocaine mixed with other drugs, including fentanyl and methamphetamine. The age range of cocaine runs the gamut from 18 to 65. And next, I'll group pharmaceutical drugs all together from a law enforcement perspective, if you will. And I agree that our state has done a fantastic job of changing the availability of pharmaceutical drugs. And it has made changes. Whether there's unintended consequences, it's really complicated to answer that question. Especially when we're in a situation we face now where our borders are more open than what they have been in the past. And our border patrol has the ability to search about 5% of the vehicles that cross our border. So it's difficult to answer that particular question. We do still see some pharmaceutical drugs on the streets. We also see some pharmaceutical drugs mixed in with the illicit drugs. We don't know exactly when that happens. It could happen during the manufacturing process. It could happen during a transportation. It could happen at the dealer level as well. There are some new trends that we have run across, although at this point we don't call them emerging threats because they're few. And I alluded to that earlier, and that's the mixing of drugs, mixing of stimulant drugs with depressants, the mixing of some illicit drugs with marijuana, with fentanyl, cocaine, meth. We've even found all of those together in pill forms. So it leads us to believe that some of that is occurring at the manufacturing and transportation process. More information, more work on that is needed. But obviously it's a concern for us when it comes to those that are using drugs. And that's all I have.
Thank you so much for that presentation, Mr. Carter, or Director Carter. Are there any questions from the committee on this issue?
Madam Chair?
Go ahead, Dr. Tice.
No, thank you, and thank you for that information, because that's what I've been hearing also, that the big concern of these drugs being brought in. Curious about that statement about methamphetamines, and for years methamphetamine use has gone down, and you mentioned it's not a designer drug. I mean, it does, as a doc, I've seen many meth addicts, and not only what it does to you mentally, but what it does to you physically. So it became less of a designer drug, or it never was a designer drug, and it's really kind of fell off. So I'm very disappointed to hear about the dramatic increase of the meth that's being brought in here. And so when you mention only 5%, you say people are checked coming across the borders. Is that what has traditionally been happening? Only 5% of the cars coming across, or 5% of the folks get checked at our border? Do you have any more data on that?
I can give more data. That's the information that we have that's happening today. And that, you know, for us is really what's the most important, is what's happening right now. But I'd certainly be able to give you more information. Sure.
So out in rural, well, I was just saying, in rural Nevada, methamphetamine labs has been a tremendous problem. Folks think it's a good place to come out and hide, and so it's been an issue for us out in the rurals. And our law enforcement will testify to this, that they'll in my own little community in Smith Valley, which you think would be protected from any of that. We've had multiple meth labs. They rent a little storage container. They think nobody's paying attention to them, and you know, they will produce their product there, and so it's real. And but we had seen some improvement, and so very discouraging to hear this pretty dramatic increase.
Well, methamphetamine has really been our #1 drug threat, I would say easily for the last 7 years. The difference we have right now is that it's the availability and the cost. The cost is very low, one of the lowest costs, yet the purity of the drug is the highest we've ever seen.
And thank you for that, because that's something that hadn't been mentioned, actually, is the cost of these drugs. And I think that the fentanyl and perhaps has gone up in cost because they're not getting it via prescription, they're having to buy it, and maybe that is why. So that's a good insight there. I hadn't thought about that correlation. Thank you, Madam Chair, for the question.
Thank you for that and the clarification from the presenter. Are there any other questions from the committee on this? Not seeing any. Thank you, Director Carter, for your presentation.
Thank you.
And we'll move on to agenda item 8. This is a really interesting area that I'm looking forward to hearing some of the progress on. We're looking at medication-assisted treatment options for substance use disorders, and an update on Senate Bill 390 from the 2021 legislative session. This bill establishes a mental health crisis hotline and provides for the distribution of proceeds from certain opioid litigation. We have Dr. Kamiar. I'm sorry if I said that incorrectly, I believe. Kicking this off with Dr. Woodard and Dr. Capurro to follow. Please go ahead and proceed when you're ready.
Wonderful. Yeah, thank you, Madam Chair and committee members. Thanks for having us today to present on this topic, medication-assisted treatment options for substance use disorders. So my name is Farzad Kamiar. I'm a physician specialized in psychiatry and addiction medicine. I'm the director of collaborative care at High Risk Pregnancy Center, where we have the Mother program. Basically, it's a program specifically designed to treat pregnant and postpartum patients with opioid use disorder. Next slide. Okay, so let's start off. I mean, everyone's been talking ad nauseum about how substance use basically is an issue and it is a problem. But some more stats here. So in 2020, 40 million people in the nation had a substance use disorder. So close to 15%, which is significant. We're setting records every year. So in 2020, more than 90,000 drug overdose deaths, which was a record. I wouldn't be surprised if 2021 was even higher than that when that data comes in. Unfortunately, because of this landscape, overdose is now the leading cause of accidental death among adults and amongst the patient population that we work with. So overdose is the leading cause of death for reproductive age women in the United States. And that's all causes, more than cancer, more than heart disease, etc. Next slide. Okay, so what is addiction, substance use disorder? I think it's important to frame this because then it leads into how we should be approaching treatment, right? If you look at ASAM's definition back in 2019, so ASAM is the American Society of Addiction Medicine. They basically say addiction is a chronic disease, much like others such as diabetes or hypertension. Here's sort of how they define it. So it's a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. What you'll notice is that there's no mention of it being sort of this choice, a moral weakness, or a failure, which is fantastic because it sort of medicalizes addiction and substance use. Next slide. So why, like what's going on, what's happening? Again, a little important to sort of understand what changes are occurring. And a lot of it has to do with the brain, obviously, but dopamine specifically. So what we're seeing is you know, in the way that humans work, life-sustaining activities release dopamine. In AKA, this is the reward neurotransmitter. We're familiar with this as in, hey, it kind of makes us feel good. Why? Well, it was designed to have us replicate life-sustaining activities. You'll see in the chart on the left, things such as food and sex, what we call natural rewards. You know, this brings some pleasure. And so ideally for the continuation of the human species, these are things that we want to continue doing, right? Where we get into trouble is if you look on the graph on the right, this is what happens with dopamine when we're exposed to substances. Just notable here is the amount of increase that happens with various substances when you compare it to sort of natural rewards, significantly speaking here. Amphetamine, you'll notice that it goes from a baseline of 100 to almost 1,000, 1,100. So it increases the amount of dopamine 10 times what something like food would. Next slide. All right, and then so this sort of, you know, repetitive exposure to these vastly increased amounts of dopamine, they lead to physiological changes. And what we see is that these physiological changes, they mimic what other, you know, physiological changes happen in other chronic diseases. So on the chart on the left, you'll notice that there's a comparison for someone who has heart disease, right? We're looking at metabolism here, red being areas of metabolism and low, you know, darker colors, blues, little metabolism. In the healthy heart, lots of stuff is going on. The heart is contracting. Diseased heart, not so much. So it's similar in the brain, right? Healthy brain, you've got metabolism going on, and then sort of someone who's been using or abusing cocaine, not so much. On the right, this is looking at dopamine and how dopamine functions and transporters that are available. Again, just notable here, you see that in a healthy brain, they do exist, and in someone who's been using methamphetamine here, it's like they're gone, right? Next slide. Fortunately, in the realm of thinking of chronic diseases, you know, we like to think that for things like asthma, hypertension, diabetes, there's effective treatments, and we are lucky that we've made advances and that there is effective treatment for addiction / substance use. It cannot be effectively cured, right? The modalities and treatments that we have now, but they can be managed. A combination of medications when they are available for that substance with behavioral therapy is the most effective. And so much so that when you put these effective treatments in place, the quote unquote relapse rates or return to substance use are comparable to the relapse rates in other chronic diseases such as diabetes and hypertension. So trying to sort of normalize that notion, you might have heard this before, that those with addiction, they're always relapsing. It's like they go into treatment and then they fall out of treatment, et cetera, et cetera. Next slide. So this notion of medication-assisted treatment, it pretty much what it means is when we can, let's use medications that are effective to treat that patient. Very important here that medications, when available, are the standard of care. Not only have they been found to be safe and effective, but we are labeling them as life-saving treatments. So these are life-saving medications. In the same way that insulin is life-saving for someone who has diabetes, medications to treat these issues are life-saving for those. But the definition is basically MAT is the use of FDA-approved medications in combination with counseling and behavioral therapies to provide what we call a whole patient approach to the treatment of substance use disorders. And again, touching on how effective this is, when someone is effectively in treatment beforehand, when they're using, let's say, illicit substances like heroin, the risk of morbidity and mortality, so basically sickness and death, is astronomical. But when they are effectively in treatment with medication-assisted treatment, it reduces that risk of morbidity and mortality almost sixfold. So it goes back down to comparable to the baseline for the regular population. Next slide. There is no maximum recommended duration of MAT. Treatment may continue indefinitely. This is where we view treatment differently. This notion of parity, right, where we're required to treat mental health and substance use disorders the same exact way. So they should be the same as we view and treat other physical issues. I'll tell you that's not where we are. There's a lot of work that needs to still go into making that a reality. But in the same way that someone might be insulin dependent for the rest of their lives, we shouldn't have this sort of bias or stigma associated with someone who's in MAT for an opioid use disorder, for example. And what do medications do ultimately? They're effective for treating withdrawal, having people stay in treatment, and then preventing what we call relapse or return to substance use. So things that are all kind of good, right? Very positive. Next slide. Currently, what we have basically for MAT, or again, that's been FDA approved, is for 3 different substances. So alcohol and the corresponding treatments that we use, disulfiram, camptothecin, naltrexone. Nicotine, you might be familiar with nicotine replacement like patches, but then some of these newer medications like Chantix, Wellbutrin, and whatnot. Topic of conversation, opioids is a big deal. It's causing a lot of morbidity and mortality. We're fortunate to have 3 currently approved FDA medications: buprenorphine, methadone, and naltrexone. So you'll notice that when we talked about MAT, we talked about adding other sorts of things like behavioral therapies and whatnot, and that's where that additional treatment options comes in. Therapy, counseling, social work and case management, peer support, mutual self-help groups, et cetera, et cetera. A lot of times addressing what we are now calling these social determinants of health is becoming really important, because kind of without addressing those, it's really difficult to get people to be in treatment to begin with. There's multiple levels of care. Level 1, sort of the lowest intensive treatment, is office-based. So this is traditional. I'm going to, let's say, a clinician's office, maybe once a month or something like that. Then there's intensive outpatient, where the designation is 9 or more hours a week of stuff is happening. But again, that's still in the outpatient setting. Residential is way more intense, and it's sort of usually in a designated space. Patients might stay there overnight, leave for the night, stay there, whatnot. And then the highest level is inpatient. So that's traditionally you're in an institution or a facility specifically to treat something that's going on. Unfortunately, we just had the topic and discussion of methamphetamine, or let's call them stimulants, that are causing a lot of death, morbidity, and mortality. We don't currently have anything for methamphetamine or a medication option for methamphetamine. Again, really unfortunately at this time, but ideally, future therapies, innovations will have something that is as effective as it is for other substances like alcohol, nicotine, and opioids. Next slide. So bias and stigma, this plays a role. I thought it was important to mention this when we talk about parity and how we view treatment. So a little bit about bias is basically, explicit, so conscious and then unconscious things that affect us. And basically it's this opinion that influences our judgment. And then another buzzword that we use oftentimes when it comes to substance use is this notion of stigma. So a set of negative and often unfair beliefs that a society or group of people have about something. Next slide. Why is it important to talk about bias and stigma? Because it's very likely that patients suffering from addiction or substance use disorder in the world of healthcare might be those that are ultimately facing the most amount of bias or stigma from healthcare in general, from members in the just the regular population, family, friends, et cetera, et cetera. Within the world of healthcare, multiple studies have demonstrated bias and stigma associated with substance use. And what effectively happens is that it's to the detriment of being able to identify these patients, have them access care and treatment. So this is why it's something that we are more and more being aware or trying to become aware of and eliminate in our approach to care. Next slide. One of the studies here was the Recovery Research Institute, just to sort of highlight that this does exist. Participants were asked how they felt about two people who were quote unquote actively using drugs and alcohol. And one was referred to as a substance abuser and another was referred to as having a substance use disorder. So this more positive person first language that we do recommend is on the blue and the right versus stigmatizing language on the left, substance abuser. What do they find? That the substance abuser was less likely to benefit from treatments. They were more likely to benefit from punishments, that it was like a result of their own fault, that they should be able to have control over their substance use without help. So that's where that bias and stigma is coming in, right? Our traditional views on those with addiction and substance use disorders. Of note, as I'll mention, that 50% of these participants were in healthcare, right? So we are not immune to this. And I think that's the end of my section. Next slide, I'll hand it off to colleagues, Dr. Capurro and Woodard.
Thank you so much. Go ahead, Dr. Capurro, when you're ready.
Oh, let me find the unmute. Good afternoon, everyone. Dr. Woodard is actually going to start us off, and then I'll take it from there.
Thank you so much. Dr. Woodard, go ahead.
Thank you, Dr. Capurro. So we will be talking about medication-assisted treatment for the opioid use disorder and opportunities that we're seeing in Nevada for programming as well as policy. Next slide. So some key points that really are highlights for this presentation. Increasing access to high-quality medication-assisted treatment has been a core strategy for Nevada for addressing the opioid crisis for several years. This includes using federal funds from our state targeted response grant, as well as our state opioid response grants, to increase capacity and enhance competencies for providers, expand service arrays, including medication-assisted treatment in federally qualified health centers, developing Nevada's hub and spoke system, as well as supporting navigation to care for high-risk populations, including those who are involved in the criminal justice system, as well as pregnant and parenting women. We also have received the Support Act grant, which is the substance use disorder prevention that promotes opioid recovery and treatment grant. This grant was awarded to the Division of Healthcare Finance and Policy from CMS, and there has been an enormous amount of work that has been accomplished through that planning grant, so much so that we have also received a demonstration grant that Dr. Capurro will be talking about. And then overview of policy considerations that relate to medication-assisted treatment, including workforce development, alternative payment strategies, and parity across payers for collaborative care for the treatment of opioid use disorder. Next slide. So a snapshot of what the current treatment landscape looks like in Nevada. We have 396 prescribers that are waivered to prescribe buprenorphine. However, not all of these prescribers are prescribing. we've done a couple of different surveys over the last several years to understand of those who are waivered, how many are prescribing, and for those who are prescribing, how many are prescribing up to capacity. And what we consistently are learning is that while we have waivered prescribers, very few are actually prescribing up to capacity if they are prescribing at all. This is an important point because we know now that we can work with prescribers to incentivize them and help to really understand what some of the barriers are from them expanding services to the patients that they serve. We also have 14 opioid treatment programs in Nevada, and they are situated primarily in our urban areas. These are what you would consider traditional methadone clinics. However, these clinics, many of them have expanded to also offering the other FDA-approved medications for opioid use disorder. We actually also have an opioid treatment program in Washoe County Detention Center. This is Nevada's first and only jail-based opioid treatment program. These programs are licensed and certified by the state and are overseen by our state opioid treatment authority. Essentially, when we look at both the OTPs as well as our buprenorphine waivered prescribers, what we find is that we actually have capacity within the system, primarily in the urban areas. But what we do lack is a connection to high quality integrated services across different systems. Our rural and frontier communities still struggle with limited access to all behavioral health services, including medication-assisted treatment, and really do require different solutions to increase the access. Parity in coverage and affordability continue to limit access to evidence-based treatment. And really addressing solutions include developing integrated treatment networks, and many states have implemented what we will call a hub and spoke system that I'll talk about a little bit later. But understanding that a hub and spoke system is a system of care where providers are really working together collaboratively to support and manage the care of individuals with opioid use disorder. Also leveraging telemedicine, and there have been some federal regulations that have been changed during the COVID-19 pandemic that has allowed for greater use of telemedicine, including initial evaluations, so that we can reduce barriers to access, especially for those that have lack of geographic access by introducing telemedicine as a facilitator for accessing care. And then increasing access within primary care providers, office-based settings, and also hospitals and emergency rooms. And one issue as it relates to stigma and bias, as Dr. Kamiar was talking about, is really finding ways that we can reduce chances that individuals are denied care because they are on medication-assisted treatment. We've seen this as an evolution within our court system, as well as with our state-funded providers that are not able to deny access to care to individuals who are currently on medication-assisted treatment. Next slide. So with this, I'll turn it over to Dr. Caporo, who will be talking about the experience of the Division of Healthcare Finance and Policy with the Support Act grant.
Thank you, Dr. Woodard. So under the Support Act, CMS developed a planning and demonstration grant aimed at increasing the capacity of Medicaid providers to deliver substance use disorder and opioid use disorder treatment and recovery services. This has been very crucial to our work. In 2019, as Dr. Woodard mentioned, Nevada was one of 15 states awarded the 24-month Support Act planning grant. And in September of 2021, Nevada was one of only 5 states that were selected for the 36-month Support Act demonstration grant. And through that demonstration grant, Nevada has also received enhanced federal reimbursement for substance use disorder treatment and recovery services, which is really key to our ability to implement our areas of focus. As part of the Support Act planning grant, the Infrastructure and Assessment Report, known as IAR, which is pictured there on the left-hand side, was created as an extensive study of Nevada's substance use disorder treatment landscape. It identified barriers and challenges to increase provider capacity, and it also included recommendations for policy and best practices to enhance and expand substance use disorder treatment services across the state. Next slide. The Support Act Core team created a 5-year strategic plan to ensure the development and long-term sustainability of provider capacity in order to meet the needs of Nevada Medicaid beneficiaries. So they selected specific areas of focus, and those include engaging the provider community to assess capacity and qualifications and their willingness to provide these services. Also developing a comprehensive MAT policy and our Medicaid service manual chapter updates, as well as providing an alternative payment methodology for MAT services. Our focus included developing and disseminating a comprehensive perinatal care practice standard and increasing SUD provider capacity through education, communication, and collaboration. Next slide. So in terms of the work that has been completed, in response to the Support Act, Nevada has developed a comprehensive medication-assisted treatment strategy. And that policy documents the process of treatment, the use of buprenorphine medications, and qualifications of providers. So we were able to adapt the ASAM criteria for Medicaid MAT policy and update our chapter. It's Medicaid Service Manual, or MSM Chapter 3800, which includes an MAT policy that was approved in June of 2020. And our MAT billing guide was published just the following month in July of 2020. We've also done a lot of work around the implementation of the Screening, Brief Intervention, and Referral for Treatment, or SBIRT codes. Those were activated in March of 2020 for a number of medical providers that are listed here. The SBIRT toolkit was developed, and training was also provided to Nevada's largest female reproductive health practice. And then using the success of that toolkit as a guide, similar SBIRT training was included in the HRSA Oral Health Workforce Grant application that the state recently completed to expand SBIRT workforce support to dental professionals. And the division continues to monitor SBIRT trends and has engaged with each of the managed care plans to discuss implementation and possible promotion of SBIRT during monthly meetings with each of those plans. We've also done a lot of work around prior authorization requirements. Prior authorization requirements have been aligned with other behavioral health provider types, and prior authorization barriers for SUD treatment have been removed and minimized. Next slide. So as mentioned, Nevada's MAT policy, the MSM Chapter 3800, went into effect in June of 2020. The SBIRT reimbursement codes were implemented in March of 2020, and the Support Act Planning Grant began in 2019. And as indicated by this graph, it's having a significant impact on the state. The chart illustrates that with more focus and awareness, you can see that there's been an associated upward trend in the treatment for OUD. And this work and these trends are really paramount. As noted by the Kaiser Family Foundation, Medicaid covers 38% of non-elderly adults with an opioid use disorder, making it the largest source of coverage for individuals undergoing Medicaid-assisted treatment. Next slide. So in January of 2021, Nevada Medicaid administered a survey to providers to assess current barriers and challenges with MAT prescribing, addressing social determinants of health, and any challenges with technology-supported informational exchanges. So 343 providers completed that survey, and they included a wide range of provider types as well as settings. The vast majority of those were self-reported experiences. And what we found was that 65% noted a limited number of organizations to which to refer to. 23% of respondents currently prescribed MAT, but 16% who did not currently prescribe did not even know if their organization had that capability. And of the 80% who were currently prescribing, 73% were not prescribing to capacity. So there's still a great deal of workforce needs that are indicated here. Next slide. So in identifying, the survey also identified barriers to prescribing MAT, and that was really foundational to developing a strategic plan. The barriers that are noted here from the survey, they largely represent topics that are also described nationally as challenges. So some of these you can see they include reimbursement limitations, limited availability of referral networks to provide that comprehensive patient-centered care coordination, the need for educational training to increase the understanding of MAT delivery, administrative barriers, and addressing stigma. These issues create barriers to successful treatment of patients with OUD and SUD and have been the focus of the state's work. In just a moment, I'll discuss an alternative payment model that's being designed to resolve the underlying underutilization of MAT services, the barriers to care coordination, reimbursement, and these administrative barriers that were identified. Next slide. The survey also gathered information on provider incentives, and they found that 39% of respondents were very willing to participate in providing MAT if there was a comprehensive alternative payment model, and 45% of respondents were somewhat willing. And so we're hoping to use these people that responded in the alternative payment methodologies that we're building. Respondents indicated, as you can see here, that some of the incentives that would be helpful included bonus payments for waivered providers, educational incentives, as well as student loan repayment programs. Next slide. So as mentioned, one of the solutions to the barriers identified in the state survey is what's called the PCOPE model, or the Patient-Centered Opioid Addiction Treatment Payment. It's an alternative payment method that's designed to improve outcomes and reduce spending for opioid addiction by overcoming the barriers in the current payment system for successful outpatient care. Next slide. And some of the specific goals around the PCOPE include creating a reimbursement structure that will support the full range of services that are provided to treat OUD, expanding the network of providers and tapping into some of those that are willing to provide treatment, encouraging a coordination of service delivery, reducing inefficiencies and unnecessary expensive treatment, utilizing evidence-based care practices that lead to improved outcomes. And some of those improved outcomes would consist of increased proportion of successful treatment for individuals with an opioid addiction, reduce spending on potential avoidable emergency room visits and hospitalizations, and importantly, reducing deaths caused by opioid overdose and complications of opioid use. The payments would be issued monthly and would be bundled set of MAT services using the ASAM guidance. And the PCOPE model as an alternative payment model also features a performance-based adjustment for bundled rates. And the PCOPE is a priority and a budget concept that the division is planning to put forward for the next budget building cycle. Dr. Woodard, I'll hand it back to you.
Thank you, Dr. Caporo. Next slide. I also wanted to talk about some of the work that's being done in the state. This is going to highlight one study, but it's certainly just one of a variety of studies where we have researchers that are working on the ground in communities with individuals who use drugs as well as individuals in recovery to better understand from their perspective what the barriers and facilitators are for accessing both harm reduction and treatment and recovery services. So this qualitative research helps to bring vital information and the voices of individuals with lived experience into our consideration when we are developing, designing, and implementing new programs within the state. So as an example, a study that was conducted by Swigart and Lee just this past year interviewed 30 individuals between the ages of 25 and 62. 16 of those individuals were currently using opioids and another 19 had used them in the past. Some of their key findings include highlighting a need for greater access to harm reduction services, as well as outreach and peer supports. Greater integration, cohesion, and interconnection between those supports and services for treatment and recovery. This is incredibly important, especially when we talk about coordinated care and collaborative care models, recognizing that a multitude of programs may be working to support one individual at a time. And it is really ensuring that those programs are able to communicate with one another to collectively support the individual in treatment and recovery services. And the comprehensive communication around what services are available, as well as what the populations of focus for those services are and any affiliated costs. Increasing opportunities for individuals who both use drugs as well as those who are in treatment and recovery to connect to purpose and community. We know that purpose and community are really two hallmarks of successful recovery programs. And when these can be fostered within individuals, there is a greater likelihood that they are able to continue on their recovery trajectory. And increased communication and information dissemination on educating what is medication-assisted treatment, how does it work, and where and how can they access those services. One of the other key findings from this research are policy recommendations, including recognizing that the criminal justice system does have a role in encouraging individuals with opioid use disorder to engage with medication-assisted treatment, integrating peers as well as supports for social determinants of health into their services and harm reduction strategies. Also, efforts to destigmatize treatment and reduce some of the criminalization and punitive practices towards individuals who have an opioid use disorder. Next slide. So I had mentioned earlier around the hub and spoke model of care. The hub and spoke model of care has been optimized by many states across the United States, really as a core best practice treatment model for coordinating the treatment for individuals with opioid use disorder. States have used federal grants to help to upstart some of the hub and spoke essential practices as well as infrastructure. And Nevada has done some of that work as well through our state opioid response and our state targeted response grants. The way that this essentially works is that the hub is a site that can initiate treatment, stabilize patients, and provide ongoing consultation to what we would consider our spoke or satellite sites, and offer access to all three FDA-approved medications for the treatment of opioid use disorder, including methadone. Spokes are also called office-based opioid treatment providers, and these can be located in a multitude of different kinds of treatment systems, including FQHCs, critical access hospitals, primary care clinics, OBGYN clinics, and even pediatrics. The office-based opioid treatment providers can work with a multidisciplinary staff, such as nurses and care managers, to provide ongoing care for individuals with opioid use disorder that tend to have more stable and less severe opioid use disorder, or for those that have been successful in maintaining maintenance for some time. They also connect patients to wraparound services, as well as supports for social determinants of health, and offer an array of outpatient behavioral health services, including counseling and case management. Again, we continue to talk about collaborative care, and we see collaborative care really as the linchpin that helps to keep this hub and spoke model intact. So the hub is really the core of where the majority of services can be initiated, but as individuals become more stable and less severe and are on more of a maintenance therapy, moving them out into the spokes or office-based opioid treatment programs can be very helpful in ensuring that we continue to have open doors of access while not overburdening some of our opioid office-based opioid treatment providers with trying to address individuals with high severity of needs and more complex disorders. Next slide. So some of the programming and policy considerations that really have been elevated during the course of our work over the last several years, and certainly have been highlighted with the work through DHCFP and the Support Act grant, include ensuring harm reduction strategies are available to all communities to support individuals with opioid use disorder, encouraging greater implementation of screening, brief intervention, referral to treatment across all primary health systems, integrating harm reduction, peer support, navigation to treatment, and recovery services into mobile crisis teams, recognizing that these teams will be going out into communities, meeting individuals where they are at, and providing additional services and supports to them. We've already started to include having overdose education and naloxone distribution as part of some of the mobile crisis teams that are already deployed into the communities. Also ensuring that there is a no barrier timely access for individuals who are seeking treatment and recovery supports, regardless of ability to pay. And this can be done through crisis stabilization centers, implementing a full hub and spoke system, and encouraging access to recovery supports throughout our communities. Next slide. Additionally, there's been work in collaboration with the Nevada Hospital Association to establish a bridge medication-assisted treatment program with emergency rooms, identifying, and we heard earlier this morning a lot about data of individuals who are coming and being served in our emergency rooms with non-fatal overdoses, and recognizing that those are opportunities to engage individuals in care and initiate them on medication-assisted treatment, and bridging that care to a provider in the community that can then continue that care onward. Also optimizing technology such as a health information exchange, the PDMP, and registries so that we can ensure timely access to medical information that is also essential to facilitate collaborative care management, and encouraging those waivered prescribers that we do have to prescribe by offering incentives and opportunities to continue to develop their competencies. Next slide. And finally, recognizing withdrawal management is not a complete episode of care, and that follow-up and referral are essential for continued support and care. I'll speak a little bit more about this in my next presentation on the sequential intercept model, but especially for individuals who are put through withdrawal management while they are incarcerated, recognizing that that in and of itself is not a complete episode of care, and that individuals who are not connected with care following incarceration are at an increased risk for overdose as well as death by overdose. So making sure that there is a linkage as individuals are reentering into the community. Also, that pregnant women with opioid use disorder can be safely cared for during pregnancy, and that neonatal abstinence syndrome can be reduced in both incidence and severity with proper care planning. Individuals in incarcerated settings who need access to withdrawal management do need the opportunity to also have induction for MAT while they are incarcerated, again, to bridge to a community provider. And that individuals who are involved in the criminal justice and court systems should also be provided access to harm reduction strategies, as well as treatment and recovery services, including medication-assisted treatment. Next slide. The decision to begin MAT and maintain medication-assisted treatment really needs to be held collaboratively between the individual and the provider, and that medication selection should be made based on the individual's preference and provider recommendations, so that we don't have outside entities such as courts really unilaterally determining what medication is most appropriate for a patient, but really keeping that decision between the provider and the patient. Also recognizing that individuals with lived experience must be engaged in the programming design considerations as we develop and implement programs across our state. It's been said many times already, but I'll say it again: parity in coverage and participation in a statewide hub and spoke like model across all payers with limitations on fail first treatment options, prior authorization, and coverage limits really does need to be considered as we're looking to build out a statewide system where individuals who need access to opioid use disorder treatment have that access regardless of their ability to pay and regardless of who their insurance carrier is. And then, of course, using and promoting telehealth as a modality for providing medication-assisted treatment services to seek options to ensure continued access to telehealth, Matt, especially considering the modifications that have been made to some of those policies under the public health emergency. And next slide. So Chair Peters, I can pause here if you'd like for us to open it up to questions to the committee as it relates to the presentation on medication-assisted treatment, or if you'd prefer, I can go into the summary of the update on Senate Bill 390.
Let's go ahead and pause here for some questions on the MAT discussion. I know I have a few, and it looks like we've got a couple of people who have questions as well. I'm going to go ahead and start with Dr. Hardy. Please go ahead.
Thank you, Madam Chair. Have we seen or been able to see the benefit of opening up the waivers, the X waivers, to people who haven't had the quote unquote full 8 hours or 24 hours? Have we seen people bite on that opportunity yet?
So this is Stephanie Woodard for the record, and I'll take this question. We have heard, at least anecdotally, that we do have more prescribers that are willing to prescribe now that they have waived some of the training and education requirements. But we haven't really fully, I don't think, understood what the impact that has had on access to treatment specifically in Nevada yet.
Right. Thank you. Thank you, Madam Chair.
Thank you. Assemblywoman Gorlo, I have you next on my list.
Thank you, Chair Peters. I had a quick question for Dr. Kamar. You describe yourself as a collaborative care psychiatrist. Could you talk a little bit more about what that is?
Yeah, absolutely. So collaborative care model, Dr. Woodard had mentioned this. It's what I foresee being sort of the wave of the future when it comes to providing mental health services for the US. Fundamentally, we have a huge mental health issue, largely untreated at this time. So if we want to use traditional care models, which is, let's say, for example, I'm a primary care provider, I've identified someone with depression, and I say, oh my gosh, let's send you to mental health. So that's traditional model, right? And then this person now needs to set up an appointment, find availability, find a provider, coordinate that with insurance, et cetera, et cetera, et cetera. We find that not only does that not happen, about 1 in 2 patients don't even show up for that referral, right, to go see that clinician. And then of those that do, a very small percentage continue care with that clinician. Okay, then there's added complexities, right? And we don't even have enough providers. So if everyone today who had some sort of mental health issue decided to go see a behavioral health specialist, overwhelmed, right? The system would probably come crashing down. But we've seen that, right? There's not, the first appointment is 6 months out, et cetera, et cetera. So what collaborative care does is it brings that prescribing and that treatment care to that primary care provider. So in our case, we have maternal fetal medicine / perinatologists in the realm of OB-GYNs, right? So our clinicians are the ones that are treating the high-risk pregnancy for these patients. They are also the ones that are seeing these patients for their opioid use disorder and providing them with prescriptions for these medications and doing follow-up. One of the cornerstones of a collaborative care program is what we call a care manager. So that's where the specialist in behavioral health comes in. And that person does, oh my gosh, all sorts of stuff, right? Figuring out how treatment is going, what follow-ups are needed, is the treatment effective, et cetera, et cetera. And then over here, sort of in this triangle, patient, the primary care, the care manager. Over here, there's the behavioral health specialist, AKA, let's say psychiatrist, for example, and that's the role that I provide at High Risk Pregnancy Center. And I basically work with the care manager, and that person is the conduit to the primary care provider / the perinatologist to inform them of taking care of these patients in something that they normally would never do. I mean, I guess you could ask Dr. Woodard, in the United States, how many perinatologists are providing buprenorphine for patients, right? You can then go to OB-GYNs, primary care providers, right? That number starts to dwindle when you go up the specialties. But effectively, we have numerous perinatologists who are now prescribing buprenorphine for these patients that normally wouldn't be getting care. I mean, we'll say pregnancy and postpartum is sort of this targeted patient population or priority patient population. But that's fundamentally how the program operates. And what it ends up doing is collaborative care, super evidence-based, right? There's numerous studies, we'll say probably close to 100, but let's say over 80, improves access to care, lowers cost, right, to deliver care, but fundamentally it actually improves outcomes. So the outcomes are much better than when we look at traditional care. And then patient and provider satisfaction is through the roof compared to traditional care models. So it's kind of the wave of the future, but the reimbursement and all sort of those motivating factors for implementing that aren't quite there yet.
Quick follow-up, Chair.
Yes, brief, please.
Okay. That was actually what I was going to ask, was about the Medicaid reimbursement. I know we'd mentioned in the discussion that that was a barrier. So are your services currently being reimbursed? And also, do you collaborate with the OB as well?
Yeah, so currently they are not being reimbursed, right? So CMS has defined collaborative care codes specifically to implement this model, but I believe Nevada is working on it because we've been involved in those discussions, but currently it's not reimbursed here in Nevada. I think we're unique. We're probably the only program that does this, that uses the collaborative care model. We've been fortunate now to be sort of grant funded, so that's what's carrying it outside of the previous years where it was just being floated by High Risk Pregnancy Center, but we saw it as basically, this is keeping people alive, right? So we're talking patient and baby or neonate and fetus. So it was super important to offer that.
Thank you very much.
Thank you. I agree. And keep us posted on how that collaboration is going with Medicaid. If there's anything that you guys need from us, please let us know. I have Dr. Licker on my list next. Please go ahead with the question.
Yeah, thank you, Madam Chair. Dr. Woodard, I want to pick up on something you talked about at a couple points, and that is use of medically assisted therapy in the judicial system. And I remember hearing a presentation a few years ago about would seem like a pretty substantial resistance and surprising resistance, even in drug courts, to using medically assisted therapy. And is that getting any better? And what can we do to get the drug court judges to be more comfortable? It seemed like some of the stigma and bias factors that we've heard about were relevant.
Stephanie Woodard for the record, through you, Chair, to Senator Ornlicker, Assemblyman Ornlicker, sorry. Thank you. It's a lot to navigate. So related to your question, I think we have seen some pretty remarkable progress through our judicial system as it relates to access to medication-assisted treatment. Some of the best practices that have come out through the national judicial court systems who provide training and technical assistance to judges and courts really have been quite progressive in helping courts and judges understand the utilization of medication-assisted treatment and how it can really enhance some of the outcomes for their drug courts specifically. We do see some courts actually bifurcating between drug court and a specific medication-assisted treatment court, recognizing that some individuals with opioid use disorder are going to benefit from sort of differentiated treatment. Where we do still see some challenges is really ensuring that individuals who are entering into any specialty court for either mental health or substance use disorder services really have adequate comprehensive evaluations on the front end to determine where there are co-occurring or comorbid behavioral health conditions, and offering opportunities for comprehensive treatment while they are engaged in care. We do know that there are many people, the majority of individuals actually, who engage in care through drug courts who also have co-occurring mental health conditions. So while we are mandating individuals to treatment through those court systems, we want to make sure that they have access to care to treat all of the disorders that they're coming with, which ultimately will benefit the individual and enhance outcomes, both in the short term, but in the long term for those individuals to meet and then maintain recovery ongoing.
Thank you.
Thank you for the question and for that information, Dr. Woodard. Dr. Titus, please go ahead with your question.
Thank you, and great, all great information. I appreciate that. Dr. Woodard, you mentioned in your early statement regarding, or you referenced, say, prison population being treated for substance abuse, drug abuse, and then making sure that they get that, as we would say as a healthcare provider, that warm handoff to continue treatment after they're released. So I'm curious, and you may not have this, or you might be addressing it in your next section. What % of our incarcerated Nevadans are actually receiving treatment for their drug addiction, not just maybe the MAP system where they're taking medication, but actually counseling and other treatments? So are all of our incarcerated people who've been identified as either having substance abuse or drug addiction being offered treatment? Are we able to reach everybody?
Stephanie Woodard for the record. Dr. Titus, it's an excellent question. And what I can say, absent concrete data, is that no, we don't necessarily have access to adequate treatment for individuals with mental health or substance use disorders within our criminal justice system, be they incarcerated in jails or in prison. Certainly there have been efforts to increase access to those services, but what I think are some of the barriers is really determining, is something like medication-assisted treatment an essential service that everyone who has an opioid use disorder has a right to be able to access while incarcerated. There is different interpretation that we have heard around whether or not it is actually considered an essential service for an individual who is incarcerated. So I do think that there is some additional policy considerations to look into that further.
Thank you for that, because in my political world, there's just a lot of comments about, just arrest them. And if we arrest them and we put them through the withdrawal or treatment program, literally by withdrawing, as you mentioned, when they get out, we may indeed see an increase in overdose. And so I just have huge concerns that we're making sure that those that we have identified get that treatment and then that warm handoff. So thank you for that, and I'd love to see some follow-up on that and maybe some actual numbers and how much are we actually lacking? I mean, what % of our prison population actually is offered treatment? And when, if you have a chance, or could get those numbers. And then my next question is regarding Medicaid. And one of the things that we heard last session was to make sure, and a bill that passed, and maybe we've addressed it, but I'm not remembering what bill that was, where the Medicaid fall that they didn't immediately lose their Medicaid eligibility when they are incarcerated, so that there wasn't that delay in getting back on Medicaid when they're released. Has that been helpful at all, or has that been implemented?
This is Dr. Kapur for the record. I think that question is to me, and I don't have specific information on that, but I'm happy to do some research and provide that back for the committee.
Great, thank you. Because there was a mention that there's that delay in getting that treatment. Even if you did have an appointment with somebody when you're released, you can't get there because you have to go through all the hoops to get it authorized. And so I just wanted to make sure that some of these changes we're trying to make have been effective, are actually starting, and some of the outcome data that we might have. So thank you all. Thank you, Madam Chair.
Thank you for those great questions. And I think many of us on this committee are interested in that workforce model issue, right? How many more do we need in the state to get to a place where we're covering everybody? And that goes across the board, but this particular issue is really important as well. I know that Dr. Kenyar has to head out here shortly, so I have one last final question for you guys related to the MAT, and then we can move on to the presentation on SB 390. My question is related to the treatment protocols for somebody who has the longer term MAT, right? So somebody who can't go through treatment and be completely off of some kind of medication to live a normal life and be productive. Can you talk a little bit about what the standards are, or if there are standards for that model, and who in Nevada is providing that kind of longer term care for folks who need it?
I can speak to that, Dr. Kammerer, for the record. So traditionally, I would say at its face, it should be no different than other forms of treatment for chronic diseases. Depending on the medication that the patient might be on, the location of that treatment might differ, but let's use one of the medications, buprenorphine, which can be prescribed in an office setting for opioid use disorder. I foresee that a patient, much like when they see us, it's just like going to see the doctor for their regular checkup and regular medication. Ideally, when we've sort of eliminated bias and stigma or destigmatized, we view this as a chronic disease and we implement treatment as such. It should be effectively no different, especially if the patient is at a place where I call it living the life that they want to live, but they're in sustained recovery, right? Abstinence or whatnot. And to them and to the community and to everyone involved, it's like they're getting their high blood pressure medication and they take it and go on with their lives.
I agree with that model theoretically. I'm just curious how many folks are actually doing that in their facilities, and what that long-term treatment looks like, and how we hand folks off, right, when we have retirements happening, or when facilities are purchased by other facilities and you have to move people. What are we doing for that continuity of care? But I think that might be a longer term discussion to have in this interview. So I appreciate all of your input and presentations. This is really some amazing work, and an effort from us to destigmatize this conversation. I know serving on the Regional Behavioral Health Policy Board up here in Washoe County, this is an area that we're looking at as well, ensuring that we're supporting folks who are providing those MNTs for our community and getting them the resources they need to continue on doing that, and working together with other community bases. So thank you so much for your presentations. And please feel free to take off. I know you have some patients you've got to see. Dr. Woodard, if you'd like to please go ahead with your presentation on SB 390, we can start there.
Sure. I'll ask Kendall to pull up the last slide of the presentation. And while she's doing that, I can go ahead and get started. So Senate Bill 390, as many of you will recall from last session, was a bill that was carried by the Senate Committee on Health and Human Services, and has two primary components to it. The first portion of SB 390 is related to 988. And what it does is it helps to establish an account, which we call the crisis response account, that a surcharge that's levied against for telecommunications is deposited into. So the first part of SB 390 is primarily focused on what we call a crisis call center. So the goal of this is to prepare us to be ready for 988. 988 is the 3-digit telephone number for the National Suicide Prevention Lifeline. That will be going live nationally, regardless of whether states are ready for it or not, starting July 16th of 2022. So Nevada has actually been working on its crisis response system for the last several years. So we were in actually a really good place to begin to do this work. And SB 390 is going to allow us to now have some revenue to be generated from the surcharge to be deposited into the crisis response account that will support ongoing call center and care traffic control, what we call like our crisis care center hub. To be able to have ongoing operations now and into the future, as well as providing additional funding to support mobile crisis teams, as well as crisis stabilization centers, with the goal of ensuring that mobile crisis and crisis stabilization centers are able to treat anyone and everyone, regardless of their ability to pay, recognizing that they are part of the critical infrastructure needed in our communities to really effectuate the change needed within crisis services. So first part of SB 390 is 988 and the crisis response account. The crisis response account has been developed and the regulations to establish the fee are underway, and we are hoping to get those approved through the Board of Health sometime this spring. The second portion of the legislation has to do with the Fund for Resilient Nevada. So this is the opioid settlement litigation funding that is coming into the state. One important point to make is that these are only the funds that the state will be receiving and not the funds that will be allocated through what is called the One Nevada Agreement to counties and cities. The One Nevada Agreement was a negotiated agreement through the Attorney General's office with cities and counties across the state who are also engaged in their own opioid litigation, recognizing that large settlements may come to the state and then need to be allocated appropriately according to this negotiated agreement to cities and counties that are also participating in that litigation, with the remainder of those funds, then approximately 43% of those funds going into the Fund for Resilient Nevada. So the Fund for Resilient Nevada has been established. The fund sits within the Department of Health and Human Services. And currently was the recipient of about $28 million from the first settlement award that the state received last spring. Those funds are being used currently to support the development of the state's needs assessment. That needs assessment is a critical component of us being able to understand what the needs of the state are, and then how that will then inform the state plan. The state plan will be used to help to allocate funding to specific activities within the state. And then around July, we anticipate having those dollars ready for distribution for the priorities that are identified in the state plan. We also are required through SB 390 to establish the Advisory Committee for Resilient Nevada. This committee was established through appointments from the Attorney General's office, the Director of the Department of Health and Human Services, as well as the Nevada Office of Minority Health and Equity. The representatives on the committee have been meeting since October, and they've been meeting monthly. So they have been helping to shape and inform the conduction of the state's needs assessment. And we're anticipating that that needs assessment should be completed within the next month or so. Chair, I'll leave it open for questions if anybody has any questions about Senate Bill 390 and where we are related to implementation.
Thank you so much for the update. Are there any questions from the committee? I'm not seeing any pop up. So I think we're ready. I know that I'm getting a little hungry and a little stir crazy. So I think we're gonna go ahead and move on to the next item, which is, I believe, presented by you, Dr. Woodard. Item number 9, sequential intercept model intersection between criminal justice and behavioral health, which is a nice tie into some of the discussion that we've been having previously. So please feel free to start when you are ready. I'm going to take 1 second to stand up and do a little shakeout of my lower back while you're getting ready. Looks good from here. Please proceed.
Okay, great. Thank you. So the next presentation really, I think, is in large part a continuation of some of the discussion that we've recently had around medication-assisted treatment. So I'll be presenting on the sequential intercept model in the intersection between criminal justice and behavioral health. And again, Stephanie Woodard for the record. Next slide. The sequential intercept model was developed as a way to identify where there are what we call intercepts or opportunities for individuals who are either at risk for becoming involved in the criminal justice system, or for those who do formally become involved in the criminal justice system, to be able to screen, assess, and facilitate access to recovery support services as well as treatment for individuals who have a substance use disorder. This model can also be applied to mental health conditions, but for the purposes of the meeting today, I will be keeping my comments and my review of specific programs solely focused on substance use disorders, recognizing co-occurring disorders within those communities. So just a brief overview of the sequential intercept model. We look at it as a continuum, with intercept 0 actually being community services, including crisis continuum. Intercept 1, opportunities pre-booking for individuals to be diverted or deflected away from the criminal justice system and into treatment. Intercept 2 occurs when individuals have been booked and are currently being processed through initial detention in initial court hearings. Intercept 3 are for those individuals who are formally incarcerated, be it in jail or prison, as well as individuals who are sentenced to specialty courts. Intercept 4 focuses on reentry. So as individuals are exiting jail or prison, and what services and supports, as well as those warm handoffs, are really essential in ensuring continuity of care. And then Intercept 5, which we consider community corrections, really focused on the role of parole and probation to support individuals in the communities. Next slide. So we see intercepts as opportunities, and there's been an entire body of research really on how optimizing these intercepts to either deflect or divert individuals away from the criminal justice system or optimize their involvement within the criminal justice system to support their engagement in treatment and recovery support services, in some of the results or outcomes that have come from that. What we have found through a lot of that research is that it reduces ongoing substance use, as well as reduces recidivism and unnecessary incarceration. It does end up ultimately reducing the risk to public safety because it helps individuals get into the treatment and connect with recovery supports that they need. It reduces overall costs of incarceration. It can be used to address racial disparities, especially those that result in over-incarceration of individuals from racial and ethnic minority groups. It has a positive impact by reducing overdoses and suicides, increases treatment outcomes, and reduces burden overall on public safety and judicial systems to address behavioral health needs. Next slide. An important part of legislation that has been passed, AB 236, I don't know how many of you are familiar with it, but AB 236 was passed in the 80th legislative session back in 2019 and made significant changes related to the eligibility for and programs available to individuals in the criminal justice system with either serious mental illness or a substance use disorder. This bill actually fundamentally changed the way that behavioral health services can be utilized, not only for those who are incarcerated, but also for the purposes of jail diversion. So there has been quite a bit of work that's been done within Nevada to support the sequential intercept model, recognizing that individuals with substance use disorders and mental health conditions who have high treatment needs really do benefit from being engaged in care versus being incarcerated. Next slide. So AB 236, as well as the sequential intercept model, can take what we call the risk needs responsivity model into consideration. So when we talk about diversion or deflection from the criminal justice system for individuals with behavioral health conditions, we also want to make sure that we can uphold public safety and identify what the treatment needs are so that we can provide what we would consider adequate dosages of treatment for the individual. So there has been a model that has been developed and it's been implemented in Nevada for the last several years, and it is called the risk needs and responsivity model. When we apply this model, what we do is we look at the risk or likelihood that the individual may reoffend and try to identify basically the propensity for criminogenic behavior. So this falls into a category of low, medium, or high. And believe it or not, individuals who are in drug court, we actually see the greatest return on investment when we identify individuals who have both a high need for treatment as well as a high risk for recidivism. So those courts really do well when they can identify that population and serve that population within drug court. So risk is really focusing on the potential risk for recidivism or to reoffend. Need, yes.
I apologize. We're having some technical difficulties on our YouTube to the public side of our presentation on seeing your presentation. Would you mind restarting it for us? See if that fixes it.
Not at all.
Sorry, thank you. Great, you're seeing it here. Let me see if they're seeing it on the public side. EPS, can you confirm that it's showing on the
Yes, Chair. This is Stephanie from Broadcast. As far as we see it, it is showing through the streams now.
Perfect. Thank you so much. Sorry again to interrupt. Please proceed, Dr. Woodard.
Thank you, Chair Peters. Would you like us to start from the beginning?
No, I think from where we were was fine.
Okay. So Kendall, if you wouldn't mind moving, I think just another slide or two. The next slide. Oh, one back, sorry. Thank you. Okay, so again, brief overview of the risk needs responsivity model. We use this model to help to identify risk for recidivism or the propensity to reoffend, as well as an individual's actual needs and how those needs might be best met as it relates to treatment. And then responsivity. And responsivity is considered all of the different factors that can contribute to an individual being able to really benefit from treatment and interventions. And this includes their needs, motivations, as well as learning styles, but other variables can also be considered. So variables such as learning disabilities, language, and the ability to access treatment in the language of preference for that individual can all impact responsivity. So we apply this model to help to identify those individuals who may best benefit from programs for deflection and diversion, as well as those who have high treatment needs that can be treated within the criminal justice system, including incarceration. Next slide. So Intercept Zero is really community services, and we differentiate between deflection and diversion by essentially saying that deflection can occur when there's no offense that has occurred. So there's no sort of like putting charges or arrest aside. We really want to make sure that individuals can benefit from deflection prior to having a risk for interfacing with the criminal justice system. So this Intercept Zero optimizes community crisis services. Law enforcement can assist with what we would consider a warm handoff to local crisis care services. And ultimately, the goal is to connect people with treatment or services instead of arresting them or charging them with a crime. Examples of deflection services in Nevada include crisis call centers, so 911 as well as 988 are our national suicide prevention lifeline. The entire continuum of services as it relates to crisis care. Our crisis response teams, down in Las Vegas, we have a crisis response team, which is a co-responder model with behavioral health and EMS. Mobile crisis teams and mobile outreach safety teams, crisis intervention training for law enforcement. This also includes harm reduction strategies, so overdose education and naloxone leave behind programs. We have a leave behind program in Washoe County in their sheriff's office. So when law enforcement is in the community on the streets and they encounter individuals that may be at risk because of opioid use, they can actually provide overdose education and leave behind naloxone for them. It also includes homeless outreach teams, as well as what is yet to be launched, but is part of AB 236, which is considered the Behavioral Health Field Response Grant, which would provide funding to co-responder models with law enforcement and behavioral health co-responding to individuals in the community that are experiencing crisis. Next slide. So a little bit about Nevada's crisis system, and this is kind of a continuation on the overview of SB 390. We have been working over the last several years to develop the crisis response system within Nevada, and specifically as it relates to 988. So the vision of the crisis response system in 988 will serve as the foundation of Nevada's behavioral health safety net. We will reduce behavioral health crises, strive to attain zero suicides in our state, and provide a pathway to recovery and well-being. And then you can also see the mission on the slide as well. Next slide. When we talk about a coordinated crisis continuum, we are talking about 3 primary rungs on a ladder, but we recognize that there are many, many different rungs or steps between these primary rungs. So the first is the crisis center. So ensuring that individuals have someone to talk to. We anticipate that by year 3 of implementing 988, we will have upwards of 99,000 individuals within Nevada potentially contacting the crisis call center through 988 to be able to access someone on the other line to help to address their issues. We also know from our own data, as well as that nationally, that approximately 80 to 90% of individuals who call a crisis line are able to have their issues resolved to a point where they may not need immediate follow-up, but that crisis call center could also connect them to follow-up care. For the percentage of individuals that do need immediate assistance, we have mobile crisis teams. So this is someone to respond. Mobile crisis teams go into the community and respond to an individual where they are at to address the crisis that they are experiencing. And then also ensuring that we have crisis receiving and stabilization centers. There has been legislation that the Nevada Legislature has passed the last 2 sessions in 2019 and in 2021 to establish crisis stabilization centers statewide. And this offers a warm and welcoming environment for individuals who are experiencing crisis with a short, more observational, less than 24-hour stay, recognizing that having a place to be able to assess and refer individuals to can also unburden some of our emergency rooms as well. And then some of the essential crisis principles and practices, which also include initiatives such as zero suicide. Next slide. So 988 is going live, as I mentioned, July 16th of 2022. And we are working currently with our PSAPs, so our primary and secondary 911 dispatch lines, to make sure that we have connectivity, at the very least, a pretty low tech way for calls to be transferred between 911 and 988, depending on the severity of the needs of those calls. Next slide. 988 is the foundation for crisis care, and we recognize that when it comes to a community response, law enforcement will still have the ability to deploy within the community as the call comes into 911. And then there is also the need for a differential response for calls that are coming into 988. But recognizing that it's more than just the call center, it's also having individuals to go into the community to work with individuals where they are on the crisis that they're presenting with, as well as having crisis facilities as an alternative door to emergency rooms and jails, so that individuals who are in crisis can be diverted from jails and into crisis centers. Next slide. So those crisis response partnerships include 911. About 10 to 15% of calls to 911 nationally are really estimated to be more crisis or mental health related. So we're recognizing that not only will the calls for 988 continue through the National Suicide Prevention Lifeline, but there are a portion of that 10 to 15% of 911 calls that also could successfully be diverted over to 988. 988 then will offer an array of interventions that are not necessarily public safety driven, and help to set forth really a cascade of care that is much more specific to the behavioral health issues that they are struggling with. Next slide. Some deflection programs that are discussed in AB 236 include law enforcement officer training to ensure that law enforcement officers have access to things like crisis intervention training, as well as how to identify individuals in a behavioral health crisis and how to adequately intervene. That reinvestments of dollars that are resulting from cost aversions through AB 236 can also be invested in a behavioral health response grant program, again, for the co-responder model for law enforcement and behavioral health to respond into communities. Next slide. Intercept 1 and diversion. So this is before the individual is arrested or before they are booked, but often after they have committed a crime or had some involvement with law enforcement. These examples in Nevada include the Law Enforcement Intervention and Mental Health Addiction Program in Clark County. Again, mobile crisis teams, mobile outreach safety teams, crisis response teams, also civil protective custody and protective custody for individuals who are under the influence of either alcohol or controlled substances, crisis stabilization centers, crisis triage centers, and then again, the behavioral health field response grant. Next slide. This is just a snapshot of our mobile outreach safety teams and the number of individuals that they are interfacing with on a monthly basis. This is a snapshot out of our behavioral health chart pack, which is generated out of the Department of Health and Human Services Office of Analytics. These are available online to the public as a public-facing link on the Office of Analytics. And what you can see here is that we have mobile outreach safety teams that are interfacing with individuals across regions in our state, including Clark and Washoe counties and our rural regions. Mobile outreach safety teams are really a co-responder model, again, pairing law enforcement with behavioral health to deploy into communities as a result of a call coming into 911 dispatch. These teams are not intended to be able to deploy as a result of a call coming in from 988. In order for an individual to be served in the community. Next slide. One example of diversion in our communities is the Law Enforcement Intervention and Mental Health and Addiction Program called LEMA. LEMA is a partnership between Clark County 8th Judicial District and Las Vegas Metropolitan Police Department, funded by the Division of Public and Behavioral Health. And essentially what is happening is law enforcement is now empowered in Las Vegas Metro when they are on the street encountering individuals in the community, that they can divert them into treatment instead of arresting them. The services that are provided through this program include withdrawal management, treatment services really across the ACM continuum, collaborative case management, weekly meetings with their case manager, connection to transitional housing and or permanent housing, as well as assistance in securing vital documents and assisting with a positive support system, including peer supports. And the programs that are utilized by the LEMA program are all SAPTA certified. Next slide. Intercept 2 can occur during initial detention or through court hearings. And this helps when they identify individuals that are coming into jails that have a higher need for treatment really than a risk for recidivism and a threat to community and public safety. There are opportunities again to divert out of the programs and into treatment. And these include our forensic assessment services and triage teams, also known as FAST teams, pretrial community supervision. So while an individual is awaiting trial, having them be supervised in the community instead of being retained in an incarcerated setting. And then some of the pre-sentencing investigation reports, again, providing a comprehensive view of an individual for the judges to consider prior to making their determinations on sentencing. Next slide. So a more detailed example of the forensic assessment services triage teams. We have FAST programs in jails in Douglas, Lyon, Churchill counties, as well as Carson City. And these are partnerships between local jails and community behavioral health providers, again, funded through the Division of Public and Behavioral Health. These participants are referred to services based on their needs, and the services can include substance abuse and mental health treatment, collaborative case management, and then a connection to temporary or transitional housing as they're re-entering into the communities. Next slide. Intercept 3, court or jail-based care. So this happens after the individual has been booked into jail. These programs can also divert individuals into community-based services through jail-based assessments and follow-up for those warm handoffs into the community, as well as through court processes and programs. Examples of these include jail-based withdrawal management programs, opioid treatment programs, and affiliation. So I had mentioned earlier, Washoe County Detention Center has started their own opioid treatment program. but there are other jails that are actually having opioid treatment programs in the community push in services into the jails to ensure that individuals have access to treatment for opioid use disorders while incarcerated. Jails are also doing a lot as it relates to behavioral health treatment programming and ensuring that programming is available while individuals are incarcerated. Medication management, including medication management for psychiatric issues, and then the utilization of specialty courts, including MHE-specific specialty courts, drug court, youth offender courts, and family drug courts, as well as veterans courts. Next slide. So as I mentioned before, I'll just touch on very briefly, Washoe County Detention Center did start an opioid treatment program. So through this program, individuals as they're coming into the jail are screened for opioid use and risk for withdrawal to determine if they may have an opioid use disorder. Medication-assisted treatment can be initiated for withdrawal symptoms, and medication maintenance is also provided as a course of treatment. And then there is a bridge to the community for that warm handoff for referrals for continuity of care for maintenance treatment and recovery support services. Next slide. Intercept 4 is reentry. So as individuals are reentering into the community following incarceration, either through jail or prison, this involves the linkage and referral to community-based services and supports. It also helps to support eligibility determinations and benefit enrollment to ensure people have access to insurance, housing, food, and employment opportunities upon reentry. Examples in Nevada include TANF, WIC, SNAP, and Medicaid benefits, specifically as individuals are re-entering into the community. We have a reentry court through the 8th Judicial District, residential treatment programs, and transitional living programs for individuals who've previously been incarcerated. Next slide. So an example is the 8th Judicial District Reentry Court. So this is a partnership between the Department of Corrections, 8th Judicial District, as well as some grant funding. They have developed a reentry court to reduce the occurrences of an overdose and relapse as individuals are reentering into the community following release from prison. So this is actually a collaborative program that started as the court system was noticing a large number of individuals re-entering after incarceration through our Department of Corrections were relapsing very quickly, most often before they were able to actually engage with parole. And it was creating a lot of issues, not the least of which is there were several overdose deaths as a result of the relapse that was occurring post re-entry. So we got together and they have developed this wonderful reentry court. They're having some amazing success. And individuals who are involved in the court have access to medication-assisted treatment, as well as an array of treatment services, collaborative care management, connection to housing, again, assistance with securing vital documents, and assistance with establishing a positive support system, including peers. Next slide. And finally, Intercept 5, community corrections. So community corrections programs help to integrate criminal justice supervision through parole and probation with additional treatment and recovery services. The goal of these programs is to support reentry into the community and reduce risk for recidivism. Next slide. Assembly Bill 236 actually did a lot of work on the portions of reentry. So several provisions regard parole and probation, and those include training requirements for individuals in parole and probation on evidence-based practices, requirements for the petition of early discharge of a person who is on parole, requirements for reentry programming and coordination with state agencies starting before the individual is moving into the community so that adequate time can be allocated to ensuring that we've got a warm handoff. But also ensuring that the consumption of alcohol or a positive drug test cannot be the sole reason for revocation of supervision. We had many individuals that we had seen being remanded back to prison because there was a relapse. And under AB 236 now, it's really seen as a relapse as an opportunity to re-engage that individual into treatment planning and an opportunity to sort of reevaluate what might be needed that was missing before to help that individual continue on their recovery trajectory. Next slide. And I believe this is my final slide. So really just to sort of put all of this together, the sequential intercept model offers many different pathways to treatment. And this really includes sort of the collaboration between law enforcement and the criminal justice system, as well as the treatment system. And really the way that these systems can work best together is recognizing when an individual has a behavioral health condition that could benefit. So ensuring that there's identification, screening, and assessment, but also referral and placement into treatment, that there's continuous monitoring and reporting of those programs that are working in conjunction with the criminal justice system to provide treatment and recovery services, and to ensure that recovery supports are available to those who need them. And this is done really through systems communication, collaboration, and case management. Next slide. And so with that, Chair Peters, that concludes my formal presentation, and I'm available for questions.
You have impeccable timing. I have my timer up and there's 1 minute and 20 seconds left of that 30-minute period. Are there questions from the committee that they would like to ask Dr. Woodard this information? I don't believe I'm seeing any. We did lose a couple folks, I think, to some other appointments, but we will reach out to you, Dr. Woodard, if we have other questions that come up on this particular issue area. Thank you so much for your time and effort in this. We really appreciate you being here with us and your expertise in this area.
Thank you for the opportunity.
Really appreciate it. We're going to go ahead and move into a lunch break. It will not be a glorious lunch break, just a brief lunch break of about 15 minutes to get us back so we can get through the rest of our agenda items for the day. We have, I think, 3 agenda items plus public comment and closing for when we get back from lunch. So at this point, if we give about 15 minutes, we'll come back around 1:05. So please be back in your chairs, cameras on, 1:05. We'll get started for the next little bit of the agenda. Thanks so much, guys.
Hold on one moment, Chair. I will let you know when we are live.
Thank you so much.
Chair, we are live and you are free to resume the meeting anytime.
Fantastic. Thank you guys so much. I know that was brief. I hope everybody got some sustenance in you to sit through the next little bit of this. Important issues coming up. I feel like after an interlude, when we last left our heroin committee, we're going to move into item number 11. This is an overview of strategies to reduce the harm caused by substance use. There are quite a few presenters on this list. I'm going to let you go ahead and get started. Please proceed when you are ready.
Hi, good afternoon, Chair and committee. I believe Lisa Lee is planning on sharing our slides.
We have Lisa Lee on right now. Yes, I see her logged in at least.
She may just be returning from the break.
There we go.
Right on cue.
Thank you so much.
Terrific. Good afternoon, Chair Peters and the committee. Oh, I just saw them pop away. Lisa, are you able to reshare?
Okay, we just lost your feed there, Lisa. Miss Lee, excuse me. Let me know if you need BPS's assistance, please. Great, we can see it again.
Next slide, please. Good afternoon. My name is Jessica Johnson. I'm here from the Southern Nevada Health District, a senior health educator there. I'm the first in the series of presenters today on harm reduction options. So I will be providing an overview and definitions. Next slide, please. Earlier today, you heard some sobering statistics from our colleagues collecting and analyzing data. A brief reminder on screen of the sobering story we're seeing here in Clark County, reflected statewide. As a country and as a state, we're painfully aware of the magnitude and cost of substance use and associated harms to our citizens and our society. These are our family members, our friends, and this is us. In desperate times such as these, it's imperative that we cast aside old thinking, acknowledge underlying stigmas, and really look to commit ourselves to public health-oriented, all evidence-based strategies forward approach. This is an opportunity.
Uh-oh, Ms. Johnson, we lost your feed. I'll give you a minute to see if we can get you back. Yes, did we lose Ms. Johnson altogether?
She's still here. It looks like her feed is frozen.
Ms. Johnson, if you turn off your camera, that may help buffer or at least audio, if you can hear us.
Chair Peters, this is Carla Wagner. For the record, I am on the docket to present here, and I have Jessica's slides if you need me to step in.
How about you go ahead, and if we get her back, maybe we can swap out again. But yes, let's just keep going if we can.
Okay. So I actually have, let me just catch up here. So I think what Jessica was saying was that in this moment, we have an opportunity to hear from people engaged in the boots on the ground work that is saving lives of people in Nevada and across the country who use drugs. Harm reduction work is work that has been done for many, many years. It has a long history in this country, long before it became a popular term that came into popular vernacular. Over the next few slides, we're going to take the opportunity to kind of share some, or get everybody on the same page about what we mean when we say harm reduction. And then we have several of us on the panel that are going to talk about specific aspects of harm reduction programming and what opportunities we have. Next slide, please. So harm reduction is a term that is used in many ways, but just to get everybody sort of connected in terms of what we're talking about today, we are talking about a spectrum or a continuum of strategies, practical strategies to reduce the harms associated with substance use. Harm reduction happens on a continuum from safer drug use techniques to reducing or managing use, all the way to abstinence or stopping using drugs for some people. But it's really focused on promoting the dignity and well-being of people who use drugs. It is more than a set of practical strategies, though. It is a framework for grassroots and social activism. It is a movement to understand structural inequalities, and we focus in harm reduction on upstream determinants of health, things like poverty, racism, homophobia, and classism that drive health-related outcomes among people who use drugs. A common way of talking about harm reduction is we say that harm reduction promotes low threshold services, and it is a way to meet people where they're at. And we mean that both literally and figuratively. That means things like meeting where they're at in the community, taking services to them. And it also means meeting people where they're at in terms of where they're at in their drug use and their life, and working with people to engender the kind of change that they value and that they can see as reasonable next steps for themselves, not imposing change on people. And there's a link here, and I believe you have these slides. Harmreduction.org is the National Harm Reduction Coalition website, and they have a really nice set of informational slides about the history of harm reduction and how we do this work. Next slide, please. So there are 6 principles that form the foundation of what it means to do harm reduction work. There is intentionally no gold standard for harm reduction programs. They're usually grounded in a by the community, for the community approach. We often say that harm reduction work is work that is done mostly by people who use drugs for people who use drugs. But the 6 principles that undergird the work that we do are health and dignity, acknowledging that drug use is complex and exists on a spectrum of use and safety. In this principle, we establish the quality of individual and community life and well-being as the criteria for successful interventions. Participant-centered services, calling for non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live. Participant involvement, by which we mean ensuring that participants and communities impacted by drugs and the interventions that we promote are at the table in the creation or discussion of programs and policies that are designed to serve them. Participant autonomy, by which we mean affirming that participants are the primary agents of change, and we seek to empower participants to share information and support each other in strategies that meet their actual conditions by giving them the resources to do so. We address sociocultural factors, recognizing that the realities of various systems and structures and systems of social inequality affect both people's vulnerability and capacity to use drugs and to reduce drug-related harms. And harm reduction is founded on principles of pragmatism and realism. We don't attempt to minimize or ignore the real and tragic harm or danger associated with drug use, but we do acknowledge that there are practical strategies that we can engage in to mitigate those harms. Is Jessica back yet?
I am. My apologies to the chair and the committee.
Do you want to take over?
Sure, I'd be happy to. Thank you. Thanks for stepping in, Dr. Wagner. Teamwork makes the dream work.
Thank you so much. Glad to have you back, Ms. Johnson. Go ahead.
Thank you. Excellent coverage of the principles. Next slide, please. The scientific literature is clear on the benefits of harm reduction and harm reduction programs. There have been over 7 governmental reports across nearly 40 years of research that cite the direct benefits of harm reduction programs. These include the prevention of blood-borne infections, stopping overdose and often reducing substance use for those engaged in syringe services programs, support of public safety, particularly through the reduction of presence of discarded syringes in the community and needle stick injuries among first responders, cost-effective interventions, so reducing healthcare costs such as preventing HIV, viral hepatitis, endocarditis, and other infections, and stigma reduction, really providing an affirming space to combat stigma. Harm reduction efforts began in the US in the late 1980s with syringe services in response to the HIV epidemic, and they've expanded in recent years within Nevada. Some of the key legislative efforts, as you've heard highlighted throughout the day today, are here on the slide to the right. Next slide, please. However, harm reduction cannot thrive if we don't also address drug-related stigma. Stigma remains one of the largest and most persistent drivers of negative outcomes for those struggling with addiction. Stigma impacts an individual's ability to participate in the various systems, social, economic, healthcare access, etc., which further erodes someone's self-worth, creating social isolation, reducing access to care, and exacerbating the issue and increasing risk of overdose death. The statistics on this slide are from a national survey conducted by Shatterproof in the Hartford and demonstrates the pervasive stigma that continues. This is among public and among healthcare professionals when looking towards improve the efficacy of harm reduction. Next slide. So a way forward, as a state, we must continue to come together around meaningful solutions, including the treatment, recovery supports, and harm reduction to end the overdose epidemic and save the lives of Nevadans. Thank you. My references are on the next slide, and I will turn this over to the next presenter if the chair does not wish to take questions at this time. Thank you, and thank you, Dr. Wagner.
Thank you so much. Like we have for most of this, meeting, I will go ahead and have everyone present and then we'll take questions at the end. So it looks like Miss Berry is up next. If you'd like to begin. Hello, welcome. Thank you so much.
Hi, thank you. Thank you for having me today. So my name is Michelle Berry. I am a senior project manager for the State Opioid Response Grant. I am housed at CASAT, which is in the School of Public Health at the University of Nevada, Reno. So we manage the State Opioid Response Grant on behalf of the Division of Public and Behavioral Health. The program aims to address the opioid crisis by increasing access to medication-assisted treatment for our opioid use disorder, reducing the unmet treatment need, and reduce opioid overdose-related deaths through prevention, treatment, and recovery efforts. And so we look at implementing prevention, treatment, and recovery support services that also are aimed towards stimulant use and misuse, and it includes cocaine and methamphetamine. For the purposes of the presentation today, I'll be going over our overdose education and naloxone distribution efforts. Next slide, please. So SOAR does cover all of the target areas that were identified in 2016 that were priority areas for Nevada. So prescriber education and guidelines, treatment options and third-party payers, criminal justice interventions, and data collection and intelligence sharing. Next slide. All of those priority areas are highlighted through these 8 major goals of SOAR. And I think that we've heard a little bit about the State Opioid Response Grant and the State Opioid Response Grant. So these are the 3 different timeframes and the dollar amounts that have been awarded to the state for the reduction in opioid use. So we did start this initiative in 2017. We were renewed for funding in 2018, and then another iteration in 2020. Next slide, please. So Dr. Woodard did go over earlier today about the development of a hub and spoke model and what that looks like for service delivery. That's what we tried to really focus on and develop during the state targeted response years. And then when we moved forward to the state opioid response, the additional provision of getting organizations ready to provide medication-assisted treatment in outpatient settings. And then now in SOAR 2, we've encompassed stimulant use disorder and expanded focus to funding residential, transitional living, and withdrawal management services. Next slide, please. So with our overdose education and naloxone distribution efforts, it started in 2018, and as of February 2022, we have 26 partnering agencies forming 42 naloxone distribution sites across the state. So the majority of the naloxone that has been distributed across the state came from two places, one being the state opioid response grant, and the other being the first responder care grant that Southern Nevada Health District had for several years. They took lead on distributing naloxone through Clark County, and then the state opioid response grant distributed to the rest of the state. With their funding ending, we're providing the naloxone to the Southern Nevada Health District to then provide to their community-based providers. Next slide. So to date, actually to September 2021, we have assembled and distributed 23,139 doses of naloxone, 21,830 kits, and we've had 1,391 reversals reported. And then to law enforcement and first responder agencies, we've distributed 6,871. So I do have it broken up because one of the questions from this morning was to whom these kits went to. So I do have some numbers. Do you just want me to submit that or talk about it now?
If you want to talk about it, that's great. If you'd like to just follow up with that information, that's, I think, also fine.
Okay, so we have it divided into service providers. Recipients are individuals who use drugs, clients in substance use disorder treatment, first responders, and community distribution. So I'll just provide the numbers instead of rattling them off today. But we do have a virtual dispensary that outlines where the sites are for individuals who are seeking naloxone. That's real time and can be found on the website, the nvopioidresponse.org. So next slide. And then Jessica can jump in and speak to the Clark County overdose plan for the distribution of fentanyl test strips. But for SOAR, we are looking at distribution going live in March of 2020, targeting harm reduction organizations and needle exchange programs for the distribution of the fentanyl test strips. And then after that, organizations that engage in street outreach and work directly with high-risk populations, followed up by law enforcement and first responders, and then our existing naloxone distribution sites that will also be distributing the fentanyl test strips within the naloxone kits. Jessica, do you want to speak briefly about your fentanyl test strip plan?
I'd be happy to. Thanks, Michelle. Clark County's Overdose Data to Action Grant received permission from the Centers for Disease Control and Prevention to utilize dollars for fentanyl test strip distribution. We have developed a training for community partners distributing test strips. To date, 32 people from 6 agencies have completed the training process. Since the launch in December of 2021, SNHD has 4 certified local distribution sites throughout the county, and approximately 2,400 strips are out at these distribution sites for clients to receive training and pickup. Thank you.
Great, thanks, Jessica. And then this is close to the end of the presentation, but I did also want to mention that the state opioid response grant does also look at other harm reduction efforts through our media campaigns that has looked at stigma reduction and naloxone and trying to normalize the use of naloxone. Zero suicide efforts that Dr. Woodard spoke briefly about earlier, screening and brief intervention and referral to treatment, and then working with organizations for neonatal abstinence syndrome focused projects. So that concludes my part of the presentation. I can turn it over to my next colleague.
Thank you so much. Looks like we have Dr. Herrera. I'm so sorry if I didn't say that correctly. But I'm not seeing her pop up here. You are here, Dr. I'm sorry. Let's see, she's on my list as in the meeting. Yes, okay, I do see her in the meeting, Dr. Christina Pereira. Oh, I apologize. BPS, is she showing up at all on your side?
She's showing up, but we're not getting a response when we ask her to unmute or turn her video on.
Okay, is it possible that we can skip through this section real quick and then come back to her when she arrives?
Chair Peters, Carla Wagner again. I have her slides and can give it a go. I'm not as familiar with this, but my colleagues can jump in if you like.
If you're comfortable with that, that's fine. Or we could, and if that is how your presentation needs to go, that's fine. Or we can wait and come back to this.
I think we can do it.
Okay, thank you, Dr. Wagner.
You're okay with that?
Yep, please go ahead.
Okay.
Thank you.
So Christina works at Track B Exchange, which is one of the 2 brick and mortar syringe exchange or syringe service programs that we have in Nevada. And so these next few slides are describing some of their efforts, and Jessica Johnson may want to jump in here at several points just to kind of flesh out the robustness of the harm reduction services that Track B is offering in Southern Nevada. But so syringe service programs, next slide, please, are one of the foundational strategies that we employ in a harm reduction way of thinking to address drug-related harms. Syringe service programs provide people who inject drugs with sterile injection supplies, which we know and have now 30 years of evidence to demonstrate can reduce the spread of HIV, hepatitis C, and other bloodborne pathogens. People who inject drugs are also at risk for soft tissue infections or abscesses and other less common infections like endocarditis, infections of the heart that can be transmitted through injection with non-sterile equipment. So syringe service programs ensure that people have clean, new syringes for every injection. They also work to ensure safe disposal of used syringes by giving people a place to bring their used syringes back to. Syringe service programs.
Dr. Wagner, it looks like we have Dr. Can you say your last name?
Hi, Pereira. Sorry, I was having computer issues.
Thank you. No, if you don't mind jumping back in, thank you, Dr. Wagner, for taking that on. We can start where you left off.
Okay.
Yeah,
so
absolutely.
I was about to say wraparound services beyond harm reduction, beyond syringe distribution.
Okay, so the last point there.
No, the second one.
Oh, okay. Sorry. Yeah, my computer crashed and I finally got back on. So, okay, so a little bit about syringe service programs. And again, my name is Christina Pereira. I'm a health educator at Track B Exchange, which is the first syringe service program in Las Vegas. We offer lots of services other than that, though, which I'll get into in a little bit. So, and these are things that we do offer, and so do many other SSPs. So naloxone, which we've talked about at length for overdose reversal, fentanyl test strips so that people can test their substances and see if they're laced with fentanyl, safer sex supplies, condoms, lube, dental dams, Plan B pills. Also, a lot of syringe service programs, including ours, offers HIV and hepatitis C testing and then linkage to care for free for people that test positive. These programs are extremely cost effective. So the lifetime cost of treating HIV is approximately $380,000, whereas the syringe costs 2 cents. And the great thing is that individuals who go to these programs often end up engaging in treatment and being connected with community resources simply because they're around providers that they normally wouldn't be around. So if you're going to, let's say, Walmart to buy your syringes, you're going in an hour, however you may get them. If you're going to a syringe service program, there are counselors there, there's peer recovery support specialists, there's pamphlets that talk about treatment services. So people are actually getting connected with some of these resources and services to be able to get them from using into recovery if they so choose. Next slide, please. So a bit about Track B Exchange's services. We are Southern Nevada's first and only syringe exchange, opened in 2017. We offer syringe exchange, and then safe disposal is a big part of what we do to reduce those needle stick injuries, naloxone medication and training, fentanyl test strips, HIV and hepatitis C testing and linkage to care. And then I'll talk a little bit more in a minute about our public health vending machines. We have 7 in Las Vegas and 1 in Hawthorne, and we are the first of the kind in the country. It's starting to catch on in other places now, but we were the first to implement these public health vending machines. We also offer medication-assisted treatment, Suboxone, Sublocade, Vivitrol, peer recovery support services. So our peers all have at least 2 years in recovery. They all have lived experience. I also do some of the peer work, and so we help people with anything from housing to getting into treatment to getting IDs, basically anything that we can help with. Getting them on the road to recovery. So also counseling, we have counselors, and everybody that is in the MAT program has to get counseling at least once a month. And then we expand our services to rural Nevada, whereas I'm sure we all know there's not a lot out there. I'm actually one of the people that goes to some of the jails, so the Lincoln County Detention Center in Pioche, and help get people on MAT there in the jail when they come in and withdrawal, and then get them hooked up with treatment if that's something that they're looking for. Next slide, please. So this is some data from Track B Exchange from 2021. So we put out 728,878 syringes, and our return rate is actually really fantastic. We took in 570,404. For Narcan, 7,099 doses. And then we track when people come in for refills, what did they do with it? Did they lose it? Did they use it? Did the police take it? So 197 refills were due to use. And of those 197, 189 of the overdoses survived, 2 passed away, and then 6 outcomes were unknown. In 2021, we had 1,172 new clients that signed up for the syringe exchange. We had 11,328 returning clients. And then 519 HIV tests conducted, with 505 being negative and 14 positive. 130 hepatitis C tests conducted, 101 were negative and 29 were positive. Next slide, please. So here's a picture of one of our public health vending machines. They're discreet. They're in. We have them in methadone clinics. We have one actually on the way in the Washoe jail. So these are nice for people that might be embarrassed to go into a syringe exchange. They can go up, they have a unique identifier and ID that they put in, and they can just not even have to talk to anyone, go up, get their stuff, and leave. It's a novel approach to an old problem. It makes it very convenient for people. So all people need to sign up is an ID, and then they can get access to any of our 8 locations across Nevada. 7 of those, like I said, are in Clark County. 1 is in a rural area in Hawthorne. All the contents are free to our clients, and they include syringes, Narcan, hygiene kits, pregnancy tests, safer sex materials, sharps containers, and first aid kits. And what's nice about these is we do tailor them to the community. So we've run into some communities where we're still trying to, to get a machine, and they say, we're not comfortable with the syringes. So we don't have to have the syringes. We completely tailor these to the community and to what they say that they need and that they're comfortable with. Next slide, please. So vending machine data from 2021, total transactions were 8,282. We put out 167,110 clean syringes. We don't have data on what we took back in as far as syringes, because next to each vending machine, there's just a large sharps container, and people just throw those right in there. So that's obviously harder for us to track. For naloxone, we gave out 514 kits, which breaks down to 1,542 doses. 429 safe sex kits, which breaks down to 2,574 condoms, 773 first aid kits, 500 hygiene kits, 237 pregnancy tests. And there's something there on the bottom that I cannot see. I don't know if
Sharps containers, 110 containers.
Okay, mine's blocked off for some reason. And so that's our vending machine data for 2021. And with that, I will wrap up my portion, and thank you so much.
I wanted to take a point of privilege real quick to just suggest something we do in engineering when we're trying to collect data on something that's a little bit abstract to collect. It's just using weight data. So if you take the weight of the container before it's has anything put in it, and then the weight after, you can make an estimate of how many you get.
Right, yeah, absolutely. Thank you for that.
Please go ahead, Dr. White.
Hi. Okay, this begins my official presentation. My name is Carla Wagner. I am an associate professor in the School of Public Health at the University of Nevada, Reno. I am here not representing the university, but speaking about kind of best practices, current research, and some emergent issues in the field as we think about harm reduction solutions. I have a large portfolio of research funded by the Centers for Disease Control and the National Institutes of Health, much of which is involved with many of the programs that you've been hearing about. So we have a study that is examining the impact of the peer recovery support services that are offered in emergency departments as part of the state opioid response and state targeted response grant that Michelle Berry just told you about. We have new research funded by the CDC that is looking at the intersection of opioid use and methamphetamine use. That's a multi-site study between Nevada and New Mexico. I also have 2 PhD students that are working on very relevant and very timely programs that you've also heard about. One who is studying the deployment of the harm reduction vending machines that Christina just told you about to look at the impact and the reach and who's using them. Another who is looking at the interest in buprenorphine prescribing among Nevada physicians and doing some early work to look at the implementation of the ED Bridge buprenorphine program that Dr. Woodard told you about earlier, where ED physicians are initiating people on buprenorphine in the emergency department before they leave. So I'm going to share first a little bit about the history of and best practices for overdose education and naloxone distribution. Next slide, please. You may know that overdose education and naloxone distribution has a very long history in the US. We only started talking about this in Nevada in about 2014 and across the US in about 2010. But the first US program distributing naloxone directly to people who use drugs was started in 1996 in Chicago. So they have a long history and there is quite a bit of data. And at this point, it's quite commonly accepted that distributing naloxone to people who use drugs must be part of our national strategy to address opioid overdose morbidity and mortality. A new article that just came out in Lancet Public Health suggests that even despite this long history, no states in the US are distributing enough naloxone to reach the targets that would signal an effective public health intervention. In this case, they were modeling naloxone used at 80% of witnessed ODs. So you just heard some data about how many thousands of kits we have distributed in Nevada. And we're very proud of that. And we're also very proud of the naloxone expansion law and the 911 Good Samaritan law that allowed us to do this at such a large scale. But what the science is telling us is that we're not getting enough kits out there and we are not getting them to the people who need them. And not just we, Nevada, I mean, we nationally. Another thing that I want to point out about overdose education and naloxone distribution, it is an education and a comprehensive training program. So when we teach people about overdose, we teach people how to recognize and respond to overdose using naloxone, and we also teach them how to prevent overdose. Naloxone distribution, however, is not a substitute for medical care and medical follow-up, and the best practice is to train people to call 911 to seek medical care when they've witnessed an overdose. This is important because as naloxone distribution has been adopted as part of our national strategy, part of what has happened is that the burden of recognizing and responding overdoses has shifted to communities of people who use drugs. So shifted away from emergency medical first responders and towards people who use drugs. And it's important to recognize that because people who have experienced an opioid overdose can benefit from follow-up medical care, not only because of linkage to services, but also because there might be experiencing medical complications that really need a professional medical response. So another challenge that we are recognizing in the national research literature is that there is conflict between the directive to call 911 when you witness an overdose and the concerns that people who are responding to overdoses have in terms of the law enforcement response that might be generated by that call to 911. Specifically, even though we have, and I believe every state in the nation has, a 911 Good Samaritan law that is designed to provide protections for people responding to overdose against charges related to drug possession, paraphernalia possession, and some other minor offenses, it's not clear that those protections are sufficient, and it's not clear that people who are in the community trust that the law will be implemented in a way that protects them. So there is some conflict between the public health imperative that people respond to overdoses with naloxone and call 911, and the criminal justice response that people fear when they're doing that. Another challenge that I want to point out related to naloxone distribution is that there has been a tremendous increase in the number of doses that have been distributed over the last many years. And during that time, we have faced many supply disruptions on the manufacturing side. We also encounter funding hiccups depending on where the money is coming from to buy the naloxone, and then also pipeline challenges in terms of getting naloxone into the right hands. And what I want to highlight there is that when that happens, the people who end up without naloxone are typically the most vulnerable. So when we have supply disruptions or funding problems, the folks who are not getting the naloxone are those most vulnerable to the consequences related to that. And so this is something that we need to pay attention to moving forward. One more challenge, just based on things I was hearing this morning, as you're all aware, there are increases across the nation in terms of stimulant-related deaths and deaths related to the co-involvement of stimulants and opioids including fentanyl. Naloxone, it can be effective in response to a fentanyl-related overdose, but it often takes multiple doses. But it cannot be effective in response to a stimulant-related overdose. So in Nevada, we have a long history of a high prevalence of methamphetamine and methamphetamine-related morbidity and mortality, and naloxone distribution is not the fix for that. Next slide, please. I wanted to spend a little bit more time on this issue of places where public health and criminal justice efforts have an opportunity to harmonize. One of the things we know about 911 Good Samaritan laws is they were enacted to reduce the perceived consequences of calling 911 to seek medical care for somebody who is dying of an overdose. And they do that by providing protection for things like possession of drugs for personal use or possession of paraphernalia, kind of low-level charges. What we know from the last decade of research with people who use drugs is that they are afraid of many, many more things than what is protected by the law. For example, possession with intent to distribute is not protected. People are afraid of losing their housing if the police or ambulance shows up to their house. People are afraid of involvement of child protective services. There's lots of things that people worry about that serve as a barrier to calling for help that are not protected by a typical Good Samaritan law. And one of the things that is emerging in the field is this issue of drug-induced homicide laws. We have one in Nevada. Several other states have drug-induced homicide laws. And these laws punish people for furnishing a substance that caused the unintentional death of the person who consumed it. The consequences are quite high. It's punishable as second-degree murder with a sentence of 25 years or life in prison in Nevada. And these kinds of laws are in kind of direct conflict with the public health effort to get people to call 911. So for many years, there have been calls to harmonize law enforcement and public health goals as a way to reduce overdose deaths, HIV transmission, and other harms. And when the criminal justice codes and the public health codes are in conflict, typically the fear of criminal justice consequences is what influences behavior rather than concern about health risk. And so what we know from several years of research is that negative interactions or fear of law enforcement leads to more syringe sharing and leads to not calling 911 for overdose. And I've done research on this topic both in Nevada and elsewhere. And this is a persistent concern among people who use drugs. And I think an opportunity for improving our public health response. Next slide. Now I will hand you over to Lisa.
Good afternoon, everyone. My name is Lisa Lee. I'm a person in long-term recovery from opioid use disorder and a program specialist for Washoe County Human Services Agency. Thank you for your time and the opportunity to speak with you today. I am here to provide information about overdose and disease prevention sites and the background on the bill, which was presented last session. The information presented here in no way reflects the views of my employer. I would like to begin by thanking the many individuals who contributed to the development of Bill Draft Request 978, which became Assembly Bill 345 in the 81st legislative session, especially Assemblyman Orentlicker, who sponsored this piece of legislation, Dr. Carla Wagner, Robert Harding, Leah Mosier, Megan Kamlasi, Dr. Chetta, Dr. Crow, and all other members of the working group. And also, I'm a terrible multitasker, so I apologize in advance. In my previous position before coming to the county, I was with Track B Exchange and launched a fentanyl test strip pilot in Washoe County. What prompted this collection of data was that during naloxone distribution efforts, folks were reporting that they were using 4 to 5 individual naloxone units to reverse one overdose. And so this all happened very suddenly, about last March. And so this prompted this fentanyl test strip pilot in Northern Nevada at that time. So it was launched from April 4th through May 16th, 2021, right before I joined Washoe County Human Services Agency. And the data indicated a 93% fentanyl positivity rate in heroin and a 67% positivity rate in methamphetamine. In my personal life, I've lost 11 folks in the last 12 months, including 2 family members, to either fatal drug poisoning or drug-related harm. And unfortunately, these personal losses are reflected in the most recently available surveillance data. Problematic substance use, reoccurrence of use, and drug poisonings have definitely been exacerbated during the pandemic. As you saw earlier, and I won't go over these slides because this is much older data than what you've heard this morning, Nevada has experienced an uptick in fatal drug poisonings. Our data in Nevada mirror national trends of increasing overdose fatalities during the pandemic, during which an estimated 100,306 people died in the US for the reporting period from May 2020 through April 2021. And just to put the human perspective back in it, that's over 100,000 people that will no longer sit with their friends and family during the holidays. Nevada has done a great job and has a multi-layer policy and funding priority strategy in place to combat the opioid crisis. The Nevada Division of Public and Behavioral Health, as you heard, has funded medication-assisted treatment expansion statewide, as well as naloxone and fentanyl test strip distribution. Further, Nevada legalized syringe services programs in 2013, prescription drug monitoring programs, the Good Samaritan Overdose Act, and layperson naloxone access in 2015. In 2021, Nevada legalized drug checking supplies such as fentanyl test strips, adding to the overdose prevention toolkit. However, again, pointing back to last legislative session, we still do not have overdose prevention sites. And I just want to confirm that when we say overdose prevention sites, this is synonymous with what's referred to as a safe injection facility or a safe consumption facility or an overdose prevention center. These are all synonymous, and I've heard a whole bunch more different terms to refer to the same thing. But these are interventions that are well supported in the literature that go back many decades. And some of the highlights that research has found are the following outcomes: that people share less. They share injection and other safe injection equipment. Syringes and other safe injection equipment a lot less, which lowers bloodborne transmission rates like HIV and hepatitis C. There's a positive correlation with linking people to services, including substance use treatment. They also encourage safe syringe disposal, which means less syringes discarded in public places. There are also less cases of public injection, so people are not injecting in public or semi-public locations. They lower fatal overdoses and drug-related injuries such as soft tissue infections like abscesses and endocarditis, etc. A recently published paper also found that there was no increase in neighborhood crime. They do not encourage drug-naive individuals to initiate use. And overall, they decrease the burden to emergency care like emergency departments and EMS services. There are a few suggestions for reading if you're interested in learning more on this topic. I believe you have the slides. So I'm going to refer to them as OPSs, or overdose prevention sites, which are an essential public health strategy designed to reduce fatal drug poisonings, reduce drug-related harms, reduce the burden on emergency services, and positively impact the lives of people with a substance use disorder. OPSs can be either mobile or fixed sites where people who use drugs can use substances that they bring on site under the supervision of trained staff and with access to safe injection supplies. While this may sound radical, the first OPS opened in Switzerland in 1986. And there are over 120 sites. Globally, there's even a Google map that maps the locations of these sanctioned facilities. The first sanctioned OPS in North America was Insight, which opened in 2003 in Vancouver, British Columbia. Insight operates in partnership with Vancouver Coastal Health, which reports over 3.6 million visits from 2003 to 2019. During that time, there were 6,440 overdose reversals with 0 fatalities, and almost 50,000 visits to clinical treatment. So Insight has a supervised consumption space on the bottom floor. On the second floor is a substance use treatment facility. And on the highest floor, the third floor, is a transitional living floor, a floor dedicated to recovery housing and transitional living. So there were no legally sanctioned OPSs in the United States due to prohibitive clauses within the Controlled Substances Act. However, on November 30th, 2021, the first OPS opened in New York City. DABIC 2022 reports that as of January 23rd, 2022, so less than 2 months in operation, there were 4,974 visits by just over 580 unique individuals, and they had already reversed 114 overdoses. There is ample evidence that support the effectiveness of OPSs in reducing individual and community level drug-related harms. Early last year, a working group assembled to discuss legislation that Assemblyman Orentlicker, an attorney, medical doctor, and health law professor, was interested in sponsoring. The stakeholder group and existing statute helped to inform the language in what became BDR 978 AB 345. The bill was set to die in committee and was amended from the original language about an overdose and disease prevention site pilot that would authorize the local health authorities in a community with over 100,000 residents. It pivoted and legalized drug checking supplies such as fentanyl test strips, which, as you've heard, our state has been able to get those out to individuals and organizations. The original language would provide opportunities for Washoe and Clark counties through their county commissions to pilot OPSs that could operate as fixed or mobile sites and be operated by a nonprofit, health district, or academic institute. The sites would offer supervision under trained staff who would provide sterile consumption equipment, the ability to reverse overdoses should they occur, and education and referrals to treatment. The local the local health districts would provide oversight, and it would be anticipated that the sites would be well studied by academic researchers. The language from BDR 978 AB 345 built upon existing legal architecture in Nevada, including hypodermic device decriminalization and authorization of syringe services programs. If anybody's curious and looking at these laws further, NRS 439.987 and NRS 439.991, layperson naloxone distribution and administration, which is NRS 435.110 and 453C.120, and the Good Samaritan Overdose Act, NRS 435C.100. So again, looking at the language in AB 345, the original version, the legislation would enable a pilot site, again, in those counties with over 100,000 residents, which after 2 years of lots of data and preliminary review would allow for other pilot sites in additional counties in Nevada, should they want those. And then after 4 years, the pilot sites could transition from a pilot after, again, a formal program evaluation, they could transition into a permanent site. And I'd like to take a minute here because I think this is really important to discuss. Originally, just a few years ago, under the Trump administration, the Department of Justice filed a civil suit to stop Safe House, which was the proposed overdose prevention site in Philadelphia, from opening. Safe House appealed to the Supreme Court in a very important Third Circuit court ruling. They did stop Safe House from opening, citing the crack house statute of the Controlled Substances Act. However, just as recently as last week, the Department of Justice did signal that it is reconsidering its stance on overdose prevention sites. And I will now, here's my references, if anyone wants to do any light reading, and I will turn it over to my colleague, Dr. Wagner.
Thank you, Lisa. Chair Peters, how are we doing on time?
Pretty good with with some of the starts and stops. We probably have about 10 minutes more.
Okay, super. All right, so Carla Wagner, again, associate professor at UNR in the School of Public Health. And I want to say one thing related to what Lisa was just telling you about the federal position on these overdose prevention sites, and that is to say, there is only a handful of people in the US doing research on these sites at the moment, but the research they're doing is quite robust. And researchers are potentially getting some signals that there is a change in the way that the feds are thinking about these things. And there's some openness to considering the data. So I think that's very encouraging. I'm going to present just a little bit of data locally. When Assemblyman Orentlicker approached us to start having conversations about what an overdose prevention site legislation could look like, Lisa and I seized the opportunity to do some data collection both in Reno and Las Vegas with people who use drugs to get their perspectives on what they would think about a place like this, because it is a priority of our research group to center the perspectives of those for whom interventions are delivered. So Lisa and I, in May 2021, did a series of qualitative interviews with people who use drugs that we recruited mostly through convenience sampling and street-based outreach. We asked them essentially, have you ever heard of an overdose prevention site? And what would you think about it? How would you like it to run? What do you see as the benefits? What are your concerns? And how, if we were to consider something like this in your community, how would you like it to be done? So this is just a quick table on this slide that shows you the demographics of the folks we were talking to. Important highlights. About 60% were unstably housed, reporting living in a park, street, abandoned house, or in their vehicle, but about a quarter were living in their own house or apartment. They were about 36 years old, a little bit more than half male, a quarter Hispanic, and just over 50% white. Next slide, please. We identified 3 big kind of overarching themes in the stories that people were telling us. People, when we asked them, what do you think about an overdose prevention site? How would you use it? What would be the benefits? What would be your concerns? People's opinions kind of grouped into 3 groups. They talked about benefits to self, they talked about benefits to others, and they talked more broadly about benefits to the community. So some of these things align with things I was talking about earlier in terms of opportunities to harmonize public health and criminal justice strategies. One of the biggest benefits that people perceived to their own selves from having an overdose prevention site in their community, someplace where they could go to use drugs under a supervised and clinically supervised environment, is that they wouldn't be at risk of criminal charges for carrying syringes. I don't know if I mentioned this on the slide where it was noted, but we are still hearing in Nevada reports of people being charged for carrying syringes, even though they should be protected under the paraphernalia law. They also saw benefits in terms of having another opportunity to access sterile supplies, to get help with other medical concerns like vein health, and to access referrals to appropriate services and care. On the right side are quotes. The numbers are participant IDs, and the Reno is that these interviews were done in Reno. And so this is people actually talking about what benefits they would see to themselves. And I want to draw your attention to the top one, because it kind of illustrates some of the themes that I was talking about earlier. This person said, I have people asked to come over. This is a housed person saying, I have people asked to come over here to my house to fix or get high. I don't want to let people do that, but I let people do it here because I don't want them to do it in the street. And that's problematic. I had one person overdose on me, which was frightening, and other people have requested to fix or get high here, and I tell them no. And I always feel bad, but I just can't risk it. It's probably how I got hepatitis. I was letting people fix at my place. So what you're hearing here is a person who has their own place, who is looking out for their friends and community members by allowing their friends to come over and use drugs in their house so that he can keep an eye on them and he can be there to respond if somebody overdoses. But that is a big burden on him. It's emotional burden, and it does put him at risk for some very serious criminal justice sanctions. And so to this person, opening a site where he could send his friends, where they could get medical care, get linked to services, and not be in his home would be an enormous benefit that he sees to himself, but also to his friends for whom he is providing this informal service. Next, please. Other people, many people didn't think they would use the site themselves, but could see how this could benefit other people, keep people from having to do this stuff in public. It says in that first quote, it would be helpful. People are talking about self-managing their mental health system. So in the second quote on the right-hand side, it would definitely be helpful, because sometimes that's why we use is to get rid of depression and anxiety. Maybe that particular person might not need heroin. They might need an antidepressant or something, and it would be a window to a door for them to be able to walk into a space that would meet them where they are, allow them to do what they need to do, and provide the opportunity to link to clinical behavioral health care. There are unique issues to women who are using drugs, women who are living on the street, and women who are seeking services. So being a woman using drugs can increase vulnerability in certain ways. And so one of the things that people talked about was running a space where there would be women's nights so that women could come together and be protected from some of the things that they face, but also have opportunities to link to services and care. Next slide. And finally, people talked about benefits to the broader community. When we asked people what would be the benefit of opening a space like this, They talked about the ability of a space like this to reduce drug use in public spaces, to reduce discarded syringes, to reduce crime, and to reduce stress on EMS and emergency responders. So in the quotes to the right, oh, I see a lot of benefits. It would save the county money on overdoses because people could be treated there. When their immune system is not as robust and they're susceptible to endocarditis, which is the heart infection that I was talking about earlier. I mean, it would save the country a huge amount of money in hospital bills, I'm sure, because indigent people requiring emergency services and transportation and things of that nature would be receiving care inside. The next person says, it's reducing public exposure to some of the most tragic kind of results of drug use. The biggest thing for me personally is that you wouldn't walk up on somebody who had died or who was dying. And if they were just able to go to this place, that would happen less. The only place for that horrible stuff to happen is out on the street in public. Where are we going to go? I mean, we don't have a spot to go. It happens where it happens. So providing people a space to come inside, to be with other people, to be supervised, not only reduces the chances of overdose death, but also reduces public exposure. And I just want to point out one data point from the international research on these sites. Many overdoses happen in these overdose prevention sites, but not a single person has died from an overdose that they have experienced at an overdose prevention site. So the take home there is people might still be consuming drugs in such a way that depresses their respiration and sends them into an overdose. But because there is supervision and there's medical personnel on site, nobody has died in an overdose prevention site. Next slide. Okay, so I guess I get to wrap this up by talking a little bit about, the slide says gaps, but I think about this really more in terms of opportunities as we think about how to move things forward in the state and in the nation. As we've talked about, I think a fantastic opportunity that we have to consider is whether there is a space for overdose prevention sites in Nevada and how we could implement those in a way that could really address some of the drug-related harms that we continue to experience. The data are out there and they are strong, that there are many potential benefits of these sites, including cost savings, reducing burden on the hospital system, and decreasing fatalities. Nevada at the moment only has 2 syringe service programs, Track B that you heard from earlier and Change Point up here in the north. And even though Track B is expanding their services through harm reduction vending machines, this is really not enough to meet the needs of the state. One of the opportunities that we see moving forward is to really make sure, embracing these principles of harm reduction, that people who use drugs are engaged in the decision-making process as subject matter experts. When we are thinking about policies and programs and services to address drug-related harms, we need to be thinking about how to get the people for whom those services are intended in the room and at the table and amplify those voices. And we can also think about that in terms of funding allocation. It's not always the case that funding for programs ends up with the grassroots organizations who have the expertise and are doing the work. So making sure those grassroots groups are also getting to the table is an important opportunity moving forward. Next slide. Housing First initiatives is a bullet point here because, as you all know, in Nevada and in many places, housing affordability and housing instability is a major problem. And the link between housing instability and drug overdose death and drug-related harms is really, really tight. They are intimately connected. And so ensuring housing stability is a step towards reducing drug overdoses and reducing drug-related harms. And then finally, for a lot of today, you heard some really fantastic data. We have many surveillance systems set up in this state that are tracking drug-related harms in terms of morbidity and mortality. I would like to suggest that one of the opportunities we have is to complement those surveillance efforts with more granular analysis of the circumstances of deaths. We are counting deaths in our mortality and morbidity reports. But if we looked more closely at the circumstances surrounding death and what was going on in those cases, I think we could get a better handle on where to place our resources and where to place our interventions. You also heard a lot today about upstream interventions, and we have to be doing all of it. And investigating a death record is too late, but it could tell us where to intervene so it doesn't happen again. And again, I would emphasize that best practices in terms of harm reduction research suggest that even in our surveillance efforts, we incorporate the on-the-ground perspectives of people who are using drugs. And with that, I think I will end and we can take questions.